Mr. Chairman, we should be live.
All right, thank you. I'll call the meeting to order. This is a meeting of a subcommittee, a special subcommittee consisting of members of labor, health, as well as appropriations to examine mental health and substance abuse programs and funding in Wyoming. As everybody knows, we've had a tremendous downturn in revenue, so our task is to figure out how we can reduce the burden on the general fund while still trying to have as little impact as negative impact as humanly possible on the folks that depend upon mental health and substance abuse services that are funded by the state and by the federal government. That's just a real brief opening. I'll have Mr. Brody call the roll, and then I'll see if the vice chair has any opening comments.
Thank you, Mr. Chairman. Senator Bouchard.
Here.
Senator Garou.
Here.
Senator Schuler.
Here.
Representative Barlow.
Here.
Representative Olson.
Here.
Representative Wilson.
Here.
Co-chairman Senator Kinski.
Here.
Co-chairman Representative Larson.
Here.
We have a quorum.
Thank you, John. Co-chairman Larson, did you have any opening comments?
No, just appreciate the work that the committee's done in the ground that we plowed on the last meeting. I think that I think that it would be important for us to focus on making sure that we keep agency budgets and programs a little bit segregated. We'll start seeing some overlap there, but there's still some distinction. And if we start to get lost, then let's raise our hands. We've got with our labor and health people here, they understand this and can kind of guide us through this a little, make sure that we're not getting, and likewise on the budget side. So, Mr. Chairman, I don't have a lot to say other than welcome and look forward to a good meeting today.
Thank you, Mr. Co-Chair. Any other members of the committee? All right. If not, then we'll go ahead and get started on the first part of our program, Justice Reinvestment Overview regarding behavioral health. And I just an opening comment, Representative Wilson, last time in our last meeting, you talked about silos, how the government was siloed. And likewise, our committees follow those same sorts of silos. The mental health, substance abuse relative to the criminal justice system. It's been touched upon by appropriations, by judiciary. Judiciary looked at it and then said, we've got as much as we can do. Now we've got to pass it over to labor health. And so we're siloed as well. So what we're hoping we're going to do today is to get an overview of several years worth of work that's been done by judiciary as well as by mental health and or labor and health regarding the role of mental health, substance abuse counseling in the justice system. Our emphasis today is just on the outpatient portion. That is when somebody is either on probation, parole, or after arrest, pending disposition or sentencing, not actually in the prison system. Otherwise, it's just beyond the scope of what we've been charged with, I believe, as does Co-Chairman Larson. So with that, we're going to have an overview from the Council of State Governments on the Justice Reinvestment Project, which was just beginning when I first entered the legislature 5 years ago under the auspices of the late Senator John Schiffer. And I anticipate that Chairwoman Wilson will be able to give us some assistance after the CSG presentations in terms of how far her group has come along in their consideration of the issue. So with that, I think, who is our presenter on this? Mr. Brody, who's presenting on?
David Diamore with CSG, as well as Stephanie. They've been admitted to the meeting, so they should be able to turn on their mics and sound and present when you let them.
Okay, I have their names here. Give me the names again. Maybe I just got the wrong copy of the agenda. Go ahead and admit them, and let's get the presentation underway, Elizabeth.
They are in the meeting, sir.
Good morning.
All right, folks, welcome,
morning.
Stephanie and David. We'll turn the show over to you. Thanks for being.
Thank you very much. Let me just kill the YouTube sound so that we don't have the sound coming over, and then we should be ready to go here.
Go ahead and admit them, and let's get the presentation underway.
They are in the meeting, sir.
All right, folks, welcome.
Good morning.
Welcome, Stephanie and David. We'll turn the show over to you. Thanks for being.
Thank you very much. Let me just kill the YouTube sound so that we don't have the sound coming over, and then we should be ready to go here.
One or the other of you still has your YouTube sound on. Stephanie, David, one of you still has your YouTube on.
Good morning.
Better. All right, I think we might be good.
Okay.
Okay, I think we're finally good. Apologies about that. Good morning. My name is David Demore. I'm a senior advisor with the Council of State Governments Justice Center. And I'd also like to introduce my colleague, Stephanie Duriez, who is also with the Council of State Governments Justice Center. I've met some of you before, and I know there are some new folks. This morning, what we're going to do is do a brief review of the history of the justice reinvestment work that we have been doing here, and then talk specifically about the behavioral health work and the beginning implementation steps from the bills that were passed this past fall and in this winter. And we'll begin by Stephanie giving you some background information, both about the Justice Center and some of our what we call phase one, justice reinvestment work. And then I will jump in after that and begin to discuss some of the behavioral health specific work that we've been doing. Thank you very much for the opportunity to give this report to you and for our ability to continue to work with the state of Wyoming. We have been working with you now for well over 2 years. I have been involved for about 1.5 years of that time and have been consistently impressed and excited by the work that is being done there and the deep sort of interest and desire to make the improvements that we've been discussing. So Stephanie, with that, I'll turn it over to you.
Great. Good morning, everybody. Thank you for allowing us to come and present to you. I'm having a little bit of technical difficulty. David, can you share your screen actually with the presentation? Apologies.
I'll let them to do that. Just a moment. Stephanie, I'm getting the same thing. I'm getting a blank option for PowerPoint. I don't know why the share is not working. I don't know if that's something that can be fixed at the at Wyoming's end, but it's coming up as blank here as well.
Does staff have a copy of the? Well, there you go. Look at you.
There, sorry, guys. Sorry, everyone. We're still figuring out all of the technology stuff as well. Let me see there. Awesome. All right. Can everybody see that? Is that full screen for everyone? Okay, great. Well, thank you, everyone. Like David said, I'm going to give us a brief overview of some of the past work that we've done here in the state of Wyoming. I know most of you are familiar with CSG, but just to give you a brief overview, make sure we're all oriented. The CSG is a region-based organization that fosters the exchange of ideas to help state officials shape public policy. So we have those 4 sections: the West, Midwest, East, and South. We do work across multiple platforms, so corrections, justice reinvestment, mental health, braintree, substance abuse, many of those subject areas we have been working with Wyoming to help address in the state. Currently, we have 26, we have 5 current states that we're working in with Wyoming, Oregon, Missouri, as well as Vermont and Maine. And we have a good history of experience with past states, 26 in total. This is a collaboration between Bureau of Justice Assistance and Pew Charitable Trust that we've been doing this work to use a data-driven approach to reduce correction spending and reinvest those savings in strategies that can decrease recidivism long-term and increase public safety. So that's really been the focus of the work here in Wyoming as well. Just to give you a brief overview of what we'll be covering today. So justice reinvestment in Wyoming, we'll take a brief look at where we are at with some of the very preliminary data. It is pretty early in the process to be looking at data as a whole across all of the different areas we've been working with Wyoming in, but we'll give you some indication of what we see so far. And then David will give us some behavioral health analysis findings and some implementation and recommendations. So some of what we are doing currently to address HEA 62 or HB 31 as it is. So when we started our work in Wyoming, we really identified 4 key challenges for the state. And that was the prison and supervision population growth, inadequate victim mental health coverage, ineffective and costly responses to supervision violations, and inadequate substance use disorder treatment. We worked with the state to really help address those issues through 4 bills. Senate enacted 19, SEA 50, HEA 45, and HEA 53. SEA 19 really allowed the courts to sentence people to unsupervised probation and impose fines related to the offense, reduce the terms of probation, and required courts to consider a set of criterion when determining the period of probation or a modification of a term. SEA 50 required that DOC revise its incentives and sanction system, allows jails sanctions of up to 15 consecutive days for serious supervision violations, allows an incarceration sanction of up to 90 days during which evidence-based services are provided, prioritizes submission into ISB based on assessed risk, and allows a person who is revoked to receive credit for the portion of time served on parole. HEA 45 extends the period within the Wyoming Crime Victim Compensation Program may allow reimbursement for victims from 24 to 36 months. And finally, HEA 53 caps the length of probation term at 36 months unless there is good cause shown, and applies the cap to probation imposed without a conviction. So where are we at with some of those earlier pieces of legislation from the what we've kind of come to call part 1 of this kind of phase of justice reinvestment? So Wyoming's justice reinvestment policies are expected to avert 18.1 million by fiscal year 2024 with all of those kind of pieces that we put into place. So current capacity is at 2,298 with projections with the new changes. You'd keep that at with the changes, the JRI impact would be 2,197, bringing you down below the capacity. So where are you at right now? Preliminary results show that policy implementation is promising. the state has actually reduced the prison population faster than the projected numbers. So at the close of January 2020, the state's prison population was at 2,308, which is really in line with those projected impacts for the state. So that's a great preliminary result that we're seeing for those prison numbers. Next is the supervised population. So the projection was that the supervision population would be reduced by 324 people by fiscal year 2024. Again, those are some of those long-term goals there. So we're a few years out for those results. But the good news is that the state is tracking exactly with projections. So we did anticipate that with some of the new policies that were enacted, that there would be just a slight incline in population on supervision. The slight incline has occurred, but it's fully within the projection that we made earlier on in this project with those new policies and coming into effect. So we would expect those population numbers to decline over time as the policies were implemented and then sustained. In addition to the 4 justice reinvestment bills passed in 2019, Wyoming designated the interim committee to continue some of that behavioral health policy work. So that's where the Joint Labor, Health, and Social Services Committee came in and really prioritized mental health and substance use as a topic, and committed to looking at the substance use and mental health services being delivered in the state to the criminal justice population. Which really takes us all the way into section 2. I'll pause though, if anybody has any questions on some of those preliminary numbers from our earlier work.
Questions from any of the committee? Representative Larson, Co-Chair Larson.
Thank you, Mr. Chairman. There was just a reference back on one of your earlier slides, and there was the term ISP, I believe it was. And I don't know what that is.
Oh, apologies, Mr. Chairman, Representative Larson, thank you for the question. ISP is intensive supervision practice. So it's those folks that are receiving more services.
Okay, thank you.
You're welcome.
Any other committee members with any questions? Then I just three very quick ones, Stephanie, and just concise answers will be helpful. Slide 7, SEA 50. Is that the bill that's referred to as having the quick dip? That is, that if somebody is offending, they're out on probation or parole, they get drunk, they're found in a bar, you don't have to wait for revocation by the judge isn't this the one where the probation officer or parole officer can say, you're going to jail right now, see you after the weekend's over?
Mr. Chairman, yes, it is.
Okay. Slide 9, the reduction in the prison population. I can't remember, it's from 349 to 308. Is that within the standard deviation? I don't know by how up and down this population is over that same period of time. It could be it's just statistical.
That's a great question, Mr. Chairman. I can definitely look into that for you, looking at the past population kind of dip valleys and peaks. It is, from my understanding, a bit quicker than we were even expecting from our conversations, but I can definitely get that answer for you about if it's within the standard deviation.
Okay, and thank you. And then the last is not a question, it's just something for follow up on, and staff can probably help you with that. Judiciary Committee in Laramie, I think this was 2 or 3 years ago. Jared might have been on the committee. We heard from Pew, from your predecessors. They studied the average length of sentence and the proportion of people sent to the state prison before the expansion of the prison and after the expansion of the prison, because the prison was online to fill up. And Pew found that the average length of sentence after the new capacity was added went from 33 months to 36 months. And the proportion of the population that was proportion of people that went to prison by the judges increased, not by a lot, I can't remember what it was, 10% or something. But the net of the combined two was enough to absorb all the additional capacity. And somebody said, so you're saying because we built it, they came? And the Pew people were very polite, and they said, no, we wouldn't say that, but it kind of sort of looks like that. So there was some discussion there about just the sentencing habits of judges and what devices might be made to help judges be aware of the resource that they're consuming, and just follow on to see what came of that statistic. And at the time, we were interested in how do you politely tell judges, independent judges who are fiercely protective of their discretion, that it's not an unlimited resource and they have to give some consideration to what they collectively are consuming in terms of what the state has available. So that's just a follow on. I'll let you get back to the presentation. Thank you.
Mr. Chairman. There's another question.
Co-Chair Larson, please. Co-Chair Larson, you've rarely been so eloquent. You're muted.
I know, and it won't get any better. It'll be downhill. So, Stephanie, can you help me remember on that House Bill 50, or was it one of those where if there was a parole violation that we would let them perhaps initially go to a county jail rather than back to prison? And if that is the case, can you help me understand if that person was on a substance abuse or mental health program as part of their parole, and they go into a county jail for a minor violation? Did we have in place means whereby they would continue that treatment while in the county jail? Are you familiar with that? Maybe I'm.
Co-Chair Larson, that's a great question. I'm actually going to punt that to David because he was working on the project at that time, and see if he can remember that specific detail.
I think the short answer is that it varies. In some cases, there was availability. In other cases, there was not. It was not consistent across the state.
And so then, Mr. Chairman and David, we might suggest then that is one of the gaps in this discussion that we would maybe try and find a remedy for, so that there would be consistency regardless of where the person is at. Is that a fair observation?
Mr. Chairman and Representative Larson, that is very fair. And in fact, as we'll talk about in just a few moments, one piece of our work and one of the goals is very much to have greater consistency across the state. I think it also loops back a bit to the issue of the judges, in that in some cases, the reason for violations or short-term dips or dunks have as much to do with concern over whether or not the appropriate services exist in the community, and a feeling that for the safety of that individual or of the community, that is the best option. So, and it becomes least of the worst of the options, in the sense of the intent is many times valid and appropriate, but it's because of what is not existing as opposed to what the actual best response for that individual might be.
Representative Wilson, please.
Chairman, I just wanted to put a thought here, just for our future consideration and carrying on to Labor Committee. There's some connection here with the whole telehealth concept. I know here in Cheyenne, and it's not necessarily specific to this sort of quick dip issue, but for example, our the residential treatment, the wing of the hospital that has might have psychiatric stays or mental health type stays, they have telehealth capability with the court, and the court, the judges are willing to do their hearings by Zoom, as it were. I'm sure it's something else, but to the folk while they are still in an inpatient stay. But so that's not exactly this, but that's something that I think, and I'm going to make a note here, as we look at the whole telehealth discussion, and that's been a major part of the mental health challenges throughout COVID and all that kind of thing that we've had. But to find out from, and I know Andy Somerville, I think, is due to testify later today. She might be able to tell us whether the community mental health centers, certainly they all have telehealth capability and are working ferociously on that. The question would be then, do the jails have the ability to set an inmate up in front of a telehealth screen? So I think that would be something that would be good to find out today and maybe follow up on. Thank you, Mr. Chairman.
Oh, excuse me. Thank you. Anybody else? Before we move on, Stephanie, just make a note on those 4 bills. You should also add to that the 24/7 bill. That was a major justice reinvestment bill. It was 24/7 for alcohol-related offenses. And in the counties that have adopted it, Campbell County, Sheridan, it's had a big impact. It depends on whether the sheriff wants to cooperate, whether the judges want to use it or not. But that's another one where you need some consistency. All right, Stephanie, go ahead and resume.
Thank you, Mr. Chairman. I will actually, with that, turn this over to David for his portion of the presentation.
Thank you, Stephanie. And Stephanie is going to continue to control the slides so that we can limit any further difficulties. So I will just say slide when it's time to shift. So what we did to take a look at behavioral health needs in Wyoming was, together with the Department of Correction and the Department of Health, we collaborated with various data folks within the departments to analyze the overlap between the supervision population, the probation and parole population, and folks that were accessing treatment. And so we were looking at the supervision population, the population of people accessing behavioral health centers, and then looking at where that crossover was in terms of the supervision population with behavioral health needs. We were looking for the proportion of folks in the justice system who had known behavioral health needs and who were accessing services through the community centers, excuse me, the proportion of people that were on supervision, and then the difference in cost or volume of services between people was another piece that we were very interested in. And then the impact of investing on treatment for returns to prison or lowering returns to prison. Slide, please. What we found, of course, is that people with behavioral health needs are accessing treatment through the community mental health and substance use centers. That's not to say that there aren't some folks who are accessing private providers, but the overwhelming number of folks who are on supervision are accessing the community behavioral health providers. There's 18 of them, private nonprofits. They deliver outpatient and or residential behavioral health treatment. As you know, of course, funding in some of the centers has been flat for a number of years, particularly depending on it being different by center, having to do in part with specific populations. Others have had sizable reductions in their funding, so there have been some of those differences. In both instances, the reality is that the amount of funding that's available for those who are under community supervision has decreased. About 50 to, depending on what part of the state or what center, 50 to 70% of people accessing substance addiction treatment in the centers are in the criminal justice system. So the overlap is amazing. I believe, Mr. Chairman, that Representative Larson is waving his hand.
Representative Larson.
Thank you, Mr. Chairman. So I'm a little confused, David, if you could, going back when you says the funding to community mental health centers has been cut, because indeed we've not cut the budget on mental health. So help me understand the premise for that comment, please.
So I think that the issue is that in some centers it has been flat. In some centers There have been reductions. It depends on the particular types of populations they're serving. It doesn't have to do necessarily with whether you cut the budget. It has to do with whether or not the dollars that are available match the particular populations that different centers are serving.
Follow up, Mr. Chairman, and so Mr. Chairman, I would just maybe request when we get Department of Health on there, we can get a little clarification on that, because I think that's an important component as we consider prioritizing populations and in funding, incentivizing funding for those populations served. I thank you, David.
Certainly.
Duly noted. Duly noted. Continue, please. Oh, Representative Wilson.
Thank you, Mr. Chairman. I was just going to say, wasn't it the case, and Representative Larson, I think this is the year that you and I went on appropriations, that when the Title 25 expenses were so over budget, I believe appropriations told the Department of Health to take that they had authorization, but they had to take it out of their own budget, and didn't they take it out of community mental health?
Representative Larson.
My recollection is the same as yours, Chairman Wilson. However, I don't know that impact was as significant as they had originally anticipated, but your point is accurate.
Well, and I think there were changes the department made to the contracts. There were some mandates in how we directed their funding and what they could or could not do with respect to collections from private insurance. So we'll have the department and the providers get into that when they come up. They understand it better than we do, and they can walk us through it. Okay, David.
Thank you. As I believe I started to mention, a very large number of folks that are in the criminal justice system are accessing substance addiction treatment, and to turn that around the other way, a large number of people that are accessing substance addiction treatment in the centers are folks who are in the criminal justice system. And of course, the characteristics of the population that's seeking treatment, their assessed needs, the level of care they need, varies across the state. That's not a surprise at all, and is typical of anywhere that one would look. Next slide, please. What we found was that slightly, and when I say what we found, this was at the time of doing the data match back in 2018. What we found was that slightly more than half of the people on supervision with a known need were accessing services at the center. And what you basically here see is the proportion of the active supervision population that had a mental health or substance abuse indicator, about 86%. The proportion of the active supervision population that was actually accessing services, so that was about 52%. And that varied depending on what district you were looking at. So in some districts, there was fairly high accessing, and in others there was not. And in some cases that related to simply whether or not services existed in a particular area, or the right type of service existed in a particular area, or the distance that it might be in terms of somebody getting to a service, or the difficulty the individual had accessing a service based on what types of needs they had, and what kind of money they had to save to get something like the addiction severity assessment to determine what their needs were. And so some of the access simply had to do with it wasn't there. Some of it had to do, so somebody needed, for example, intensive outpatient, but it might not have been available. Some of it had to do with timing in terms of how long it took. And that, again, not being a fault of anything, but a system problem in terms of how assessment happens or has not been happening consistently across the state, which is something that we're going to talk about in a moment in terms of really looking how to fix that and make that flow much more smooth and have it move much more quickly. Next slide, please. As I mentioned, they were not connecting particularly quickly, regardless of their level of risk. Again, numerous reasons. There might be a delayed referral by the agent in some cases. There might be a wait list at the center. And to be clear, A wait list at the center doesn't mean that they weren't seen initially, because they would be, but then there might be a period of time before they could access the actual ongoing group work. They might be accessing services at a private provider, and that's a it's a very small number, but there are some of those folks. There's the issue of people just simply not showing. And so the delay has to do with the fact that the client is being difficult and not showing. One of the things that we also saw were revocations prior to appointment. And part of that, again, being related to the issue of how long it took to get in to access, and then transportation needs. So again, a variety of different needs. But what we found was that if you look at the chart on the left, a significant number of the population, it was more than a month before they were accessing services. We know that those first weeks in the community are extremely important, and the potential for failure in those first weeks is extremely high. Next slide, please. Whoops, I'm sorry, Mr. Chairman, it looks like Representative Larson has his hand up.
Please, Representative Larson, thank you. Thank you, David.
So David, do we have a feel as to why the long wait?
There are multiple reasons for the waits. There is no one reason that we discovered as we went around the state. As what we did after the initial looking at these numbers was that we literally did a roadshow around the state to visit all the different centers. In some cases, and so the reasons that you see on the right of this chart, all of these sort of fed into this. In some cases, the delay had to do with it took longer for the referral to happen than we would say should take. In some cases, it had to do with the resistance of the client and simply not showing and then having to be resent and rescheduled and get back in again. In some cases, it had to do with the distance the client lived from the closest relevant service, and the transportation needs were so difficult that it was difficult to get them there, and then this snowballs, right? Then they fail, then they're revoked. So it's hard to say that there's one thing. It's sort of this combination of different components that you see in terms of the delay. Another piece that also related to the delay is that and we'll come back to this again, was that when we look at the addiction severity index, the assessment that people need to take to determine level of care needed and to get into treatment, that in many cases, they had to get a new one, even if they'd had one relatively recently, because it wasn't following them. It was not going with them to the new provider. And depending on where that might be, those costs were different. In some cases, those costs were zero, so that didn't play into it. In other cases, those costs were over $100 or a couple of $100. There were a couple of outlier costs as well, but that was generally the range. And that person would then take, would need X number of weeks to save up that money in order to do that. And so that time would pass, and again, there would be a delay. So multiple reasons, no one reason. We can't say it's because the centers were not responsive, because they certainly were to the best degree that they could be. We can't say it's because agents, didn't refer, because overwhelmingly they did. But when you start adding up all of the different sub pockets of issues, you end up with the series of things, sometimes integrated together, that creates the wait list and the time delay with people getting in. But the key, the biggest issue that we wanted to start with when we were looking at this, and again, we'll get to this in a moment, was really getting a smooth flow in terms of the initial assessment, getting that to follow the individual, and getting there being no delay based on waiting to determine what that treatment need was. That alone can have a major impact on access to services and speed to access to services.
Follow up, Mr. Chairman.
Please.
So is that assessment, that COMPASS assessment that is performed by Department of Corrections, or where does the assessment come from? Is that through Department of Corrections or through the Department of Health? And is there a collaboration there to accept whichever one?
Mr. Chairman, Representative Larson, those are two different types of assessments. The COMPASS assessment is what's called a risk and needs assessment, looking at criminogenic risk and needs. which is indeed done by the department, and it helps determine supervision level. It helps determine correctional treatment needs. It identifies needs that are related to particular criminogenic risk factors, factors that make it more likely for someone to recidivate. The Addiction Severity Index, or the ASI, is specifically looking at the substance use needs of the individual and what the level of care is that is required for them to do well, to get through treatment. The ASI could be done by the DOC if somebody is in DOC, and it is done by DOC in many cases. It can be done by community providers. It can be done by private providers. It is an assessment tool that is not tied to a particular department or a particular group of individuals, other than in Wyoming, you must be a licensed clinician to complete the ASI. You don't need to be a licensed clinician to complete the compass. You simply need to be trained in how to complete the compass. So they're two different tools. There's some overlap, but there is a difference in focus. The compass is overwhelmingly what we would consider to be a correctional assessment tool, where the ASI we would consider to be a behavioral health or substance use assessment tool.
Thank you, Mr. Chairman.
So, David, if you could make your responses a bit more concise, I'm concerned about time. So, for point of information, Representative Larson, the ASI, by statute, or at least there's a statute that's been widely interpreted and applied to say, you, Mr. DUI suspect, you will pay for that entirely yourself. There will be not a dime of state subsidy, which sounds like a real righteous cause, except you have people sitting in jail for months waiting for an ASI, so so they sit in jail at $80 a day instead of us helping them out with the cost of a $150 assessment. All right, David, let's move on. Forge on.
Next slide, please. What we found was that high-risk clients who receive mental health and substance use disorder services remained in the community for 305 additional days on average. Or in other words, what we found was that, in fact, when people were able to access both mental health and substance use services, they did better. Their survival curves were better. Their failure rates were lower. Their return to prison or jail was less. That, in fact, intervention is effective. That when folks have the appropriate intervention, they do well in the community. And there's an improvement and certainly a cost savings in terms of folks that you have not being reincarcerated. Would you go to the next slide, please, Steph? Key takeaways from the analysis: more than half, 57% of the folks on probation and parole supervision with an indicator of mental health or substance use need access to at least one of the community mental health and substance use centers. The rates of people on supervision with an indicator of need for treatment who access the services varied across the state, with a rate as high as 66 and 80% in some districts and as low as 38 in others. That targeting high-risk people with treatment services is associated with longer stays on supervision without being revoked, and likely positive net savings relative to the cost of days in prison. Mental health treatment, which is mostly outpatient, is less expensive than substance use disorder treatment, but it has a weaker association with longer stays on supervision without a revocation. That's not in any way to suggest that it's not important, simply that substance use addiction causes a much higher failure rate for individuals. More analysis ultimately will need to be conducted to understand in each specific area why folks are not accessing services, but we were able to really look at the reality of the differences in terms of services not existing in certain parts of the state and people having to go to other parts of the state to access those services, and the distance even when there was something local. While I think there's some continued need to examine subpopulations, it is fair to say at this point that the issue of distance and location of relevant services are the two overwhelming issues in terms of the issue of distance access. In other words, not getting in. And the third one being the issue of the cost, as the chairman mentioned, in terms of getting the addiction severity index completed, et cetera. Next slide, please. So in response to all of that, of course, HAA 0062 was passed in March of 2020, saying that the Department of Correction would collaborate with the Department of Health to reduce recidivism rates for folks with behavioral health needs and substance use disorders involved in the criminal justice system, looking at improving the quality and accuracy of the assessments that are administered, creating a quality improvement unit within the Department of Correction, and for the Department of Correction and the Department of Health to jointly collaborate in terms of looking at that unit and determining what needs to happen and what needs to be looked at by that unit, creating a behavioral health services enhancement program for community providers to improve outcomes for folks that are involved in the criminal justice system through contract revisions, adopting a standardized evidence-based treatment practices and guidelines for treating and providing programming to folks that are involved in the criminal justice system, and increasing the communication between the Department of Health and the Department of Correction and the contracted behavioral health providers. And then finally, to create a competitive and outcomes-based funding stream for behavioral health providers to expand existing services, to improve the quality and availability, and to train and develop the skills and providers of stakeholders. Next slide, please, Stephanie. So we are helping, the piece that we are doing, the Justice Center, in terms of our continued technical assistance, is working with Wyoming to implement these components. One, we're providing targeted support that is basically working with your state to look at other states that have developed similar processes, like quality assurance units, for example, and how they have done that, and how the Departments of Health and Corrections work together in those areas. By engaging the stakeholders in a collaborative and consensus-based process that strengthens agency cooperation, which I'll come back to in just a moment when we talk about the implementation pieces. And then, of course, as always, by measuring performance, collecting data, monitoring outcomes to ensure that the implementation is data-driven. And we're providing funding in the form of an implementation grant that is made available by BJA, which is passed through the CSG Justice Center and then on to Wyoming. I need to, with a minor caveat, that final formal approval for that funding, we do not have it yet. It will be coming in the next month or so. We have every reason to believe that it will be happening, but just to be perfectly final approval of that for this phase is about a month away from BJA. We've certainly been told that that is coming, but I do want to make it clear that it's not quite here yet. Next slide. So in terms of implementing the recommendations, next slide. So there were an additional set of implementation priorities, right? Establish the quality assurance unit within DOC, WDOC, develop standardized evidence-based guidelines for treating people in the criminal justice system, and then expanding the sharing or the portability and acceptance of assessment results. Next slide, please. So establishing the quality improvement unit within DOCs to ensure statewide consistency and sharing of the addiction severity index, or the ASI results. So the development of the QI unit model, working with WDOC and WDH to identify the goals and expectations that they have, as well as providers and other stakeholders, in order to design the unit to meet the needs of the system, as well as, of course, meet the legislative intent. And then the second piece is developing the policy and practice guidelines by developing quality improvement policies and procedures that are specifically related to the assessment process. And that's being done in conjunction with WDH. And I just want to make a quick statement and say that we have now been working for a while with the behavioral health unit in WDH and working with WDOC and it has been a great process. Folks are really very involved, very invested, and working very well together and working well with us. And we have also added representation from the community providers so that we truly have all of the necessary components, if you will, of folks that are concerned with these treatment issues involved in the development of this model and looking at what kind of training will be happening in the coming months. The anticipated outcomes are that there'll be a greater consistency of the behavioral health assessments that are delivered across providers. The people in the criminal justice system will be better matched to treatment and receive the relevant programming to address their behavioral health needs, to reduce recidivism, increase in successful treatment, and a decrease in revocations and returns to prison. Next slide, please. The second component of that has to do with developing a standardized evidence-based guideline or set of guidelines for treating folks in the criminal justice system. So develop clear and consistent treatment standards and train providers on those standards. Our funding will provide training for providers on the theoretical foundations of the ASAM criteria, the Society for Addiction Medicine criteria, clinically driven services, biopsychosocial assessment, continued stay, transfer, discharge criteria. That will be provided to representatives from the community mental health centers, as well as WDOC providers and WDH representatives as well. Secondly, to develop and implement the QA process to monitor the adherence to the new guidelines, providing training on a formal structured decision-making tool for providers to use to increase the consistency of their treatment practices of folks that are in the criminal justice system. And then the third and very important component, increasing the collaboration between DOC, WDH, and providers. Again, providing training this time to the core implementation team within the WDOC and the WDH, as well as the providers, to ensure collaboration and sustainability. So what we're attempting to do with our training opportunities that we're providing Wyoming is to provide a variety of different types of training related to substance use, related to working with the criminal justice population, relating to interagency and community and governmental agency collaboration in how to effectively respond to this group. We anticipate for outcomes, behavioral health assessment and treatment practices to be delivered more consistently, that community treatment providers will be better able to support clients in the criminal justice system by understanding and addressing their unique challenges. And again, looking to increase successful treatment completion, looking to decrease the cycling through WDOC and the community providers, and looking to decrease the revocations of folks. One of the things that we're very excited about is that we're able to provide funding for the state to move to a computerized assessment of the addiction severity index. And what that will do is that all of the providers, the community providers that are providing services to these individuals, will have access to this at no additional cost to the centers. This will also allow for aggregate data to be collected for the quality assurance unit to be able to look at and monitor and assess the consistency, coherency, quality of the assessments as they are done, and then to look at the need for types of services that individuals might have and whether those exist in that particular area of the state. And so in terms of doing that, we're looking at the issue of expanding the sharing and acceptance of substance use disorder, mental health, and co-occurring assessment results, requiring providers to accept ASI assessment results completed within the last 6 months if no significant life event has occurred. And again, by utilizing this new system, they'll have access to that in a much easier way than it has been now. The difficulty in getting it, even when folks have been trying to get it, has been significant in some cases. This will allow for the easier and appropriate transfer of that information from DOC to providers, or from provider to provider, or from provider to DOC as relevant. This second piece has to do with revising the policy regarding the sharing of the ASI, again requiring providers to share the results of the assessments in accordance with the established QA policies from the unit. And then thirdly, as I led with, investing in the use of the computerized ASI. We anticipate that this will lead to an increase in cooperation between the state agencies and the community providers. And I should say between state agencies and between state agencies and community providers. We're looking to have a decrease in the number of folks who have multiple behavioral health assessments administered without a qualifying reason for a number of reasons. One, it's a waste of resources. Two, it's part of what related to delay in access to service. And three, we found inconsistent results with not a lot of logic as to why assessment 1 differed from assessment 2 with a period of just a few weeks between them and no other significant life events having occurred. A decrease in the amount of money spent by clients on duplicative assessments, and a decrease in the time it takes for people to get into treatment. Next slide, please. So what are we expecting in terms of looking at this implementation over time? Well, what Wyoming should see is more folks successfully completing mental health and substance use treatment, fewer folks failing supervision and entering prison, people accessing critical services more quickly, treatment providers delivering higher quality behavioral health assessments and treatment more consistently across the state. And as I've always said, whenever I've testified to any of your committees, I want to make it clear, you have a lot of really good providers. We're looking to improve what is an already set of good folk. And I don't want to suggest that this improvement is because people are doing bad things. That is not the case at all. We've been very impressed with many of your providers. A decrease in financial burden placed on clients forced to pay for duplicative assessments, and an increase in the collaboration and cooperation between state agencies and the community treatment providers. Next slide. The expected timeline you see here in terms of looking at this, by this coming October, the QI unit should be in place and working on the policy and practice developments. By November, the implementation and sustainability training that we are providing the funding for will be provided, as well as the providers being trained in the ASAM criteria. By December, the development of the treatment standards and guidelines and the providers trained in those. All providers by that time using the computerized ASI for folks in the criminal justice system. By January, community providers receiving additional training in the structured decision-making tool to improve treatment matching. In February of 21, all trainings are provided. The guidelines will have been finalized, ASI fidelity support wrapping up. By March, we essentially will be done in terms of our TA, our direct involvement, but we will continue to do data monitoring forward after March and April as we collect the data in conjunction with WDOC and WDH for reporting back to the Bureau of Justice Assistance, the folks that are funding all of this. And last slide. Thank you very much for listening.
Thank you. Representative Larson, please.
Could we, thank you, Mr. Chairman. Could you go back to the previous slide, David, please? So as I follow that timeline over, we come January 2020, should that be 21?
That absolutely should be. We apologize. That should absolutely be 2021.
I thought I was very good. That's all I had.
Okay, we began this section at 8:35. We're scheduled to wrap up at 10. It doesn't look like that's going to happen. We have 3 more presentations, but before we do that, I want to make sure we get committee questions. Representative Olson.
Thanks, Mr. Chairman. So as I kind of try to consolidate all of this down, I see 3 overarching issues: cost, access, collaboration. Seems like House Bill 62 is attempting collaboration between YDOC and Department of Health and then with the community health providers. Cost, we've already talked about. Cost being, how do we make that more fair and equitable? You look at a county like Sweetwater, 80% of you're saying the population has mental health and substance abuse issues. Crook County has 36%. So, but you're averaging out at 86% of Wyoming population. Seems to me, I think we all agree, getting the funds equitably as we can across counties is going to be a consideration. Now, access is part of that. And access is the question I have for you. Chairman Wilson had mentioned telehealth. I have for a long time been very curious about telemental health, telecounseling in this particular area when we're talking about outpatients in the DOC system in probation and parole. I'm curious, David, what you see and know from other states in terms of their use of telehealth, particularly for mental health and counseling. When I look at Wyoming, I think that one of the issues that we have is a burden and a blessing, and it is that we are so rural. So we're talking about rural areas where we're trying to get services to these offenders sitting in a county jail. And I saw your map there. You had your map where obviously some have mental health, some have substance abuse treatment centers, some don't have anything. And so access could be the old school way, I guess, brick and mortar, build a building, more community providers, build satellites to those community providers, whatever that may be. But telehealth may be a part of the pie and a huge solution for Wyoming. So help me understand what you know about other states in terms of their use and success with mental health, counseling, et cetera, in this area.
What I can tell you is that telehealth has exploded around the country as a result of COVID-19. I am myself a clinician, and for the first time in my 40 plus years of work, have been seeing clients over Zoom and other appropriate venues, if you will, and styles. There is certainly initial evidence that telehealth, and specifically telemental health, substance use treatment, is a viable alternative. I don't think that there's anything that suggests that it is better. And I think we also need to look at determining what kind of treatment is needed. And so what telehealth, of course, cannot replace is the need for residential treatment if somebody has a level of care that requires residential treatment. But if you're looking at what we would consider to be general or regular outpatient treatment, and in some cases, even a slightly more intensive phase of that, it can be utilized. I would never suggest it as the first choice. I would suggest it as a reasonable option when you can't build the bricks and mortar that are necessary. And you are not the only state that is in that position. Other states with large rural areas are using telehealth more and more because they simply cannot physically create the number of physical facilities that are required to meet the need. What I do think is important is that there has to be a very clear determination about what level of care is agreed upon as appropriate when doing that, and when that simply is not sufficient to provide the appropriate level of care. So it's not an all or nothing. It's a yes, this makes sense. It makes sense for certain groups of folks, and we need to sort of have a thoughtful process. And we can certainly share a couple of other states that are working on that and looking at standards about it, and not too far from Wyoming, actually, that you can also talk with and get some ideas from.
Representative Wilson.
Mr. Chairman, before we dive out, I just, sorry, a quick follow-up. I wanted to follow up on the offer, David's offer, to provide some data and information on what some other states, particularly that look like Wyoming's rural setting, are doing. And then just, sorry, I'm really sorry to cut you off, Chairman Wilson, but in case you wanted to dive into a different topic, I didn't want to lose I only had one question, which was on cost. Obviously there's an upfront cost to a brick and mortar facility, but overall, what does a cost comparison look like? I mean, in terms of what you pay the provider, for example, are the rates higher with telehealth, lower with telehealth, similar? Set aside the brick and mortar building itself, what do the costs look like?
Mr. Chairman, Representative Olson, that's an excellent question, and I don't have the answer at my fingertips as to that. We do have folks that do have that information and are working on that particular area. And along with connecting you with other states, I'm happy to gather that cost information for you and forward it to the chairman, and he can forward it to, or to Elizabeth, and they can forward it to the rest of the committee.
Elizabeth, please. Okay, Chairman Wilson.
Thank you, Mr. Chairman. Just actually following on Representative Olson's discussion. So I do know that all of our community mental health centers have gone to pretty much all telemental health during the COVID-19 crisis. They're all working that way. They can do initial intake in person, but then it's pretty much all, I mean, they've been using that for a long time because we have such a shortage of psychiatry. The main challenge from my understanding, and even here in Cheyenne, which of course is less rural than most parts of the state, is that many of the clients don't have, either they may not have good cell coverage at their house, or they may be in a place where there's no broadband. So the cell and broadband infrastructure is really the main challenge there. Our mental health providers are actually pretty used to providing the services. And I would say that in Wyoming, so I would suspect that there's probably the block grants to the mental health centers, I'm sure, don't differentiate. Their insurers pay the same for the most part as if the person is being seen by remotely or in person. So I think that that's probably not the main issue. I think the main issue, from my understanding, is, and we can hear later, I know we've got some of the provider folks coming on, but the client's end of not having the internet or the phone or the laptop is really the problem, I think.
Thank you. Anyone else? Senator Schuler.
Thank you, Mr. Chairman. I just had a question to kind of follow up with Representative Wilson. In terms of COVID, I wondered if these implementation milestones, if these dates are still fairly realistic, or do you think that COVID will cause some issues with being able to accomplish some of the things that CSG has talked about? Thank you.
Mr. Chairman, Senator Schuler, the short answer is we actually made a number of changes as a result of COVID. And so all of the trainings that we're talking about were originally scheduled to be in-person trainings. They are now all web-based trainings that are being done because it's the only way to do that. There's some possibility that the January training would be, January 2021 training would be in person, but in all honesty, just sort of looking at the way things are going, we anticipate that all of these trainings will be web-based, and that is how we will be able to meet the timeline. It is a tight timeline. We have a little bit of wiggle room in that we are able to remain with you all until the end of March. So if we do have to push something out, we have a little bit of room, but we've tried to account for the COVID issues by moving all of these things online. And fortunately, the two providers that we're working with, the other consultants we're working with that will be providing some of this, have the ability to provide all of these trainings in a web-based format.
Thank you. A bit of housekeeping, if I may, real quick, for John and Elizabeth. When I chair, I like for staff to keep track of requests for information. And at the end of the day, I'm going to ask you to recap those in the format of who is it that asked, Representative Olson, of whom was it asked? They asked David Demora, and what was it they requested? And we just want to make sure that we have those all lined up. And at the end of the day, it seems as compelling as it was at the beginning of the day, but also it just helps us, I think, know what we've got coming in a follow-up memo from various folks. Other questions? Okay, so these are just a couple of real quickies that I have for David and Stephanie. I did not see implementing a sliding fee scale on the cost of the ASI at one of your recommendations. Is that implicit in there? Did I miss it?
Actually, it's better than that because of the fact that we are able to now provide the funding for the ASI and that it will be computerized. There does not need to be the kind of charges that existed previously. There still is some discussion in terms of what that cost will be, but it definitely would be a sliding fee scale. It wouldn't be a high flat rate. Our goal is to get that as low as possible.
And that's all being covered by BJA?
Yes, the cost of the ASI, the computerized ASI, is being completely covered by BJA.
Okay. And then this is just a note for Elizabeth and John. When we get DOH on, we want to find out that the latitude they've given these providers for telehealth during COVID will be continued. And if it's not, whether they need legislative authorization to do that. David and Stephanie, I noticed, I can't remember which slide it was where you were talking about, it was slide 25. You have the providers in DOC and DOH. You also need on there probation and parole, the judges, law enforcement, district attorney, county attorney, multidisciplinary teams. You know, you can have the community mental health center, can be all dressed up and ready to go. And if you have a county attorney that says, oh, I just don't believe in that. Okay, well, where do we go now? Or a judge that says, you know, that community mental health center, all they ever do is put people on outpatient. I'm using this private provider over here. Well, you're dead in the water at this point. So they have to be included in your education. And then somehow you need to QI the behavior of the judges, the county attorneys, the prosecutors. I mean, are they availing themselves of these tools? Because the community mental health centers, the providers can't do it because they're part of a continuum of healthcare. And Representative Wilson will recognize that phrase, the continuum of care. And everybody in that continuum has to be bought in. And that includes, and most especially, the police, DAs, county attorneys, judges, and maybe that's implicit in your slide.
Mr. Chairman, thank you for that question. In fact, we didn't discuss that because we weren't particularly providing that TA with this funding. But in fact, one of our recommendations and discussions is that as WDH and WDOC get through this training, that they, along with and the community providers get through this training, that they, the community providers, WDH, WDOC, a couple of your sheriffs that are working in this area and a couple of your judges that are working in this area provide a statewide training opportunity where they would do this by region over the course of probably a year to provide training to those various individuals that you just mentioned, because that is absolutely imperative. It is beyond the scope of what we're doing to look at developing QI related to those other groups.
Okay.
But Wyoming may indeed decide that's something they want to move toward.
All right, thank you. So Senator Bouchard will be here in just a moment. Elizabeth, John, please make a note when DOH comes on that I'd like for them to immediately begin gathering the dates of the sheriffs and chiefs, the county court conference, the district judicial conference, the state bar conference, all of those, and start gathering those dates. And you might start looking for panel time at each of those presentations by DOH. You've got to start now to get months in advance to get on those things. And then just one more before Senator Bouchard. I would like David or Stephanie for you to give me a recap of who you are, how the funding comes. It started out, I thought it was Pew, but I remember now it was Pew, it was CSG, it was a collaboration. But at the outset of this, CSG and Pew said, we're not going to do it unless we have a letter from the Speaker, from the President of the House, the AG, the Governor, and the Chief Justice saying they're all committed to this process and that it'll be a collaborative process across all branches of government. We now have a new Speaker, a new President, a new Governor, a new AG, and a new Chief Justice. So in terms of getting cooperation from all aspects of the system, we might want to find out how we renew that commitment, assuming this is all part of that same process that was started 5 years ago. Senator Bouchard. Oh, go ahead, David.
This is all part of that same process, and we have in fact been in contact with a variety of individuals, but we can loop back as necessary in terms of assuring that the continued interest and support is there. We've seen nothing to suggest otherwise.
Okay, Senator Bouchard.
Thank you, Mr. Chairman. You know, one thing I just want to make as a comment, that the most important part of some of what we're looking at here is the health department and the corrections coordinating. So, I mean, there's a lot of things, a lot of moving parts when someone goes in on addictions and then has to come out. I mean, we want to make sure that there's a coordination, so that way there is communication between those two agencies. But I have a question for David, because I was excited about all this when this was happening. But as I start diving into it deeper and I look at how we know there's lawsuits with assessments where we've had assessments that were done on the outside by a provider, and then when they go into corrections, they have been reassessed and found that they're had possibly DUIs or other indicators that they know that maybe it slipped through the crack on the outside of the system because the provider didn't have access to some of the information. And so these assessments aren't across the board even. So we know that there's problems with the outside of corrections and then the inside of corrections. And then as I look at how other states do things, if I look at Montana, just a simple search, I see that Montana has a Montana Association of Addictions Professionals, and they have an affiliate. They're an affiliate of NADAC. I look at Colorado, I see the same thing. And these are the same things that I keep bringing back into committee, that we have states that actually recognize addictions professionals because they are able to use a peer-to-peer model and build trust with, have addictions professionals that maybe have been through this whole process of being incarcerated themselves, becoming felons, having it in their heart to come back into a prison system or into a local setting through a community setting, some of them in drug court systems in various states. But those professionals are more geared in these other states to what we're trying to do here. And I'm just seeing that we're not doing the same model here. So my direct question is, how do we fare doing this with maybe not addiction professionals, just on the addiction side, compared to other states that have advanced way beyond us? So I'm just seeing not apples to apples here on some of this with addictions.
Mr. Chairman, Bouchard, there's no easy answer to your question because there is not the consistency that you would anticipate from state to state. Some states have completely separate groupings of addictions and mental health. Some states have departments of mental health and addiction services. Some states have separate addictions folks. Some states require you to have the higher, what would be considered to be a higher clinical level of treatment or training and licensure. I am not aware of a study that says one is better than the other. I have seen studies that have shown every model, when implemented well, working well. And I've seen studies that have shown when they're implemented poorly, working poorly. What I would say simply is this: regardless of how Wyoming decides they want to go in terms of this, what is important is that there be clear standards and training that is required of anybody who is seeing somebody with an addiction issue. One of the big failures that you see are the use of peer supports without training and structure, and that tends to be a disaster. The use of peer supports with training and structure tends to be very effective when it's being done in conjunction with whatever other treatment intervention is occurring. So I don't have an easy answer. I don't think it's a one or the other. And then the last thing that I'll just say about that is the important piece is to be clear about, regardless of, again, how you determine that it should look, whoever it is that's providing these interventions also needs to understand the issue of co-occurring disorders, because the number of folks with substance addiction issues who have a co-occurring mental health disorder is fairly significant. So however you structure it, you determine that, of course, but structure it, make sure that the training and guidelines and requirements are consistent regardless of whoever it is you decide you're going to authorize to be able to provide these kinds of services.
Richard, based on what I just heard there, it might be a nice option for you over the interim to reach out to WAMSAC and to David and see if you might, if you're going to bring your bill back, to see if you might do it in a way that you still have the peer professionals, but they're in that structured sort of setting like David's talking about for maximum effectiveness. And there might be a win-win there. I don't know. Yep, please, Senator Bouchard.
Mr. Chairman, I mean, the bill that I brought was specifically inside of prisons, and they have a separate mental health provider in the prison. So, I mean, I don't think that really is the same as what, obviously the first time I worked on this, I wanted to go wider and make sure we allowed addictions professionals to work in the state. So, I mean, there's two different issues. So I appreciate the comment.
Okay.
Though.
All right. All right. Folks, it's three. I show which of my watches is going to be most accurate. 9:55. We still have three folks that want to present. If there's not any more questions, I'd propose we take a 7-minute break. Any more questions for David or Stephanie? All right. According to my clock, it's 9:55. I'm going to set an alarm for 7 minutes. That gives everybody a chance just to hit the restroom, grab a soda pop or whatever.
Mr. Chairman and members, thank you so much for the opportunity to speak with you.
Well, you're not leaving, are you?
No, sir. We'll be hanging around.
All right. Super. 36 seconds is what I show. I better close that TV off. It'll drive everybody nuts. John, Stephanie, you ready to go? Or it's not Stephanie, John, Elizabeth, you ready to go?
I believe so, Mr. Chairman.
Okay, let's, it's 3 after, my alarm just went off, so let's go ahead and resume.
Mr. Chairman,
Co-Chairman Larson.
I'm with you, but we don't have a quorum.
Oh, they just haven't turned their cameras back on. All right, well, so housekeeping wise, Elizabeth and John, you can go ahead and tee up Cheryl and Andy and Paul. And let's set our cap on a half hour for these 3. That'd be 10 minutes each, or however they want to allocate the time. That may not be realistic, but let's give it a shot. Okay, 1, 2, 3, 4, 5. Looks like we have a quorum.
Yep.
Who's first up?
Chairman, I believe Cheryl should be first, and we are admitting her right now.
Okay. Tell me what admit means. I mean, is there any reason not to admit Andy and Paul at the same time as well, if they're co-presenting with her?
I do not believe they signed up to co-present. They signed up as individuals giving public comment on this topic.
Okay, gotcha. Cheryl, welcome.
Folland.
Cheryl, you're gonna what? There you go.
There we go. Thank you. Cheryl Folland, Legislative Advisor, Wyoming Association of Addictive Professionals, and independent private provider in Rawlins. Thank you, Mr. Chairman, members of the committee. I wanted to take a moment to thank the committee for the opportunity to speak today and for your continued presence in addressing these topics that are so important to our members of our state and those that are even just coming through as part of our corrections department. I did want to address a couple of things in CSG's presentation that I think is important for the committee to understand. That obviously CSG's, and I've had the opportunity to work with them in 2 other states where I was practicing, Kansas and Texas. Their research obviously is to the centers, to the mental health centers of the state. There are many of us in private practice who see folks out of the Department of Corrections. I personally have 6 clients that are on probation and parole, as are many of my peers and obviously members of our membership. I did want to address for Representative Olson that as to cost, specifically on the ASIs that are provided by several different providers. I'm only reimbursed $50 for an ASI. So if somebody can get me the $150 that CSG proposed, that would be wonderful. But that doesn't happen. We also have a situation where providers within the court system specifically have to go through the Department of Behavioral Health to be an approved provider for assessments and for programs. And that is a cost to us, and it is kind of a convoluted process. So many of my peers and colleagues choose not to participate because of that process for those of us in private practice. So there is a resource available if we can get through some of the bureaucracy of being a certified provider. I did also want to address with Representative Olson's comments on telehealth that yes, it is a wonderful tool for us. As Representative Wilson and Senator Schuler also pointed out, bandwidth is the biggest challenge that we see, especially myself and Rollins. I think we have one cell phone tower within the whole 200 miles. So I can't even do telehealth with my clients that are in Bags or Elk Mountain. Saratoga is kind of hit and miss. If you get up on the hill, you might get a signal. And that is very much a challenge that does go to failure to our clients because they get frustrated. They can't access the services that they need. Of course, they do the dual diagnosis. We do have those co-occurring disorders. And that does enhance a person's risk to reoffend or to have a probation or parole revocation because they get frustrated. They can't access the services that they're told that they have to have. One of the other pieces that I wanted to address very quickly is that specific to the ASI, the only training required for an ASI is basically online. And it's a do-it-yourself type of a study program. I've been trained in 3 different states on the ASI and with the federal government when I was at the VA. So for me, it wasn't a big issue. Wyoming doesn't regulate the assessments that we use other than just identifying them, that it has to be an ASI. The training is hit or miss. There is no real quality assurance to the training. There is also, as David had identified, there are definite inconsistencies. One of the challenges that we have, and I believe Senator Schuler and Representative Wilson, Senator Bouchard have addressed in Labor Committee, is that our licensing standards also play into the delivering of these assessments as well. You do not have to have an addictions background to provide this assessment. You also, with a license in Wyoming, if I have had one class in addictions, then that makes me qualified to do substance abuse services. I was very fortunate. I started my career with my associates in addiction studies, and then moved.
If I could interrupt you for just a second. So I think these are addressed by their quality standards. Are you endorsing the quality standards that they've been advancing, or is this a deficiency in the presentation that we heard? Or I'm having a hard time seeing where you're going here. Help me out. You've been talking for 8 minutes.
Sorry, thank you, Mr. Chairman. Yes, to both. There's a deficiency in the quality standards and a deficiency in the data.
And does their recommendation address that?
It only addresses it for the community mental health centers. It does not address it for the other providers in the state.
Okay, I've got it. All right, thanks.
And with that, the other deficiency is not all providers use the electronic version of the ASI. Many providers do use just paper and pencil. And with that, thank you for the opportunity to speak, and I stand for any questions.
Any questions for Cheryl? Representative Barlow.
Thank you, Mr. Chairman. So my question is, and other provider types and the agencies can certainly respond to this too, is one of the things we've heard about is an ASI completed in one setting, say Department of Corrections, then goes out, that individual goes out into the community setting, and there's a desire to do a reassessment. And then they change settings again, and there's another reassessment. And so I guess one of the things that we talked about through this process, and Department of Health will be up soon, is making sure that we have some portability or some transferability in these assessments. And that goes to, you know, how they are being accomplished. So do you have any thoughts on that? Thank you, Mr. Chairman.
Please, Cheryl.
Thank you, Representative Barlow, Mr. Chairman. The biggest component to a good assessment is number one, training, but number two is the fidelity of the assessment, making sure that it is being done properly. And we do not have that ability at this point in time. We do have bachelor's level people who can be very competent, who are addictions professionals, who have training and education with this tool. Then we have master's level practitioners who have maybe had one class and don't really understand how the tool is supposed to be delivered. And that is one of those things that we do find those inconsistencies, why we have the lawsuits. It is a problem.
Okay, thank you.
Any other questions for Ms. Folland? Thank you, Mr. Representative Barlow. Any other questions? All right, Cheryl, thank you. Greatly appreciate you being here. Andy Somerville, WAMSAC. Andy Somerville looks suspiciously like Paul Demple. All right, Andy.
All right. Well, thank you, Mr. Chairman. Andy Somerville, representing WAMSAC, your community mental health providers. I just have a few brief comments. I'll just start out with saying the process with CSG, working with Department of Health and Department of Corrections on this project has been wonderful. I just have to echo their sentiments about everybody being at the table and participating. So I want to thank them for that. And then I just wanted to run through a few points, a few questions that were asked. So regarding county jails and telehealth, I believe Representative Wilson asked that question. That has come up in discussion, and I apologize if my committees are blending together, but I believe it was in the Judiciary Committee meeting. They discussed telehealth funding for county jails, DOC, and I don't know of any bills that are coming forth to provide additional funding, but I know that that has been discussed. From our perspective, it does vary from county to county based on the county jails' abilities and how they prefer to do things in their county. We do have, I believe, 4 jail-based contracts. They are DOC contracts to the community mental health centers to go in and provide services. That's a relatively new thing that's come out. And like I said, we've only got 4 of those so far. but definitely a conversation in the works as we see that as a way to continue to provide services. And I just want to clarify, we do have services in all 23 counties from the community mental health centers. So even the rural areas still have access to services, but the downside is that what services they have direct access to in what I would consider a realistic transportation area do vary by centers of the state. The question, I believe, from Representative Olson on the cost of telehealth versus brick and mortar. So we've been looking at this for quite a few months. We had dived into telehealth prior to COVID, but obviously with COVID, we've ramped up that expectation of telehealth availability significantly. What we're finding is the actual cost to the centers to provide telehealth is really not different right now than brick and mortar. The bulk of the cost is in the provider's salaries. So regardless of whether it's telehealth or they're seeing somebody in person, you still have those costs. Moving to a full telehealth model, if you could get rid of the brick and mortar, you could realize some savings there, but we don't see a significant cost difference right now. Let's see. To Co-Chairman Kinski's question about any legislation needed to continue telehealth practices, two things that I wanted to highlight for you. One is the insurance parity bill. That was brought forward, I believe, from the Labor Health Committee earlier to potentially go to a special session. We think that bill is important. With COVID, the insurance companies have stepped up and are paying telehealth visits as they are in-person visits. And that's really important because it was really challenging before and really varied. So we think that bill is important to keep that moving forward so that telehealth is a viable tool in the toolbox. Also, we've had to request and have been successful. Everybody's been very great about this. A number of changes to Medicaid payments in terms of allowing both audio only and then audio visual traditional telehealth services to be covered without consideration of where the clinician is versus where the patient is. There were some pretty strict rules. Those have all been relaxed for COVID. We want to continue to look at those and keep the rules that make sense and that were actually utilized in the future. That's a conversation both with our state Medicaid office and then with CMS at the federal level, because they do provide a lot of guidance. And then the last, so to be specific, Co-Chairman Kinski, I'm not sure if legislation is needed. I think that might just be an executive function of the state Medicaid office, but I'll follow up on that and communicate with you if we do see a need for legislation on that. And then also we're working with SAMHSA right now, that's federal, to keep some of the changes that they have put in place for COVID. Things like before you had to have an in-person visit before they could be put on a MAT therapy, a medication assisted treatment program. They relaxed that during COVID, and we're kind of tracking that and looking at, is that effective? Is that a change we should keep? So we're looking at all of those things right now. As I understand it, a number of insurance companies had initially planned to roll back their changes in August. I don't think that's still the case right now, but we're trying to follow that pretty closely. And then if I can share my screen, the last piece I wanted to touch on was just the question of funding from Co-Chairman Larson about what that's looked like. And let's see. Can you guys see that? Yep, okay. So on the left is a presentation that I believe Department of Health gave last year that shows the funding by source to the community mental health centers. And so you can see we're pretty much in the ballpark for direct contract pieces since 2013. But we certainly haven't seen a significant increase. And I want to highlight there was a significant decrease after the 2016 year. The centers all took a direct cut to their contracts. And then on the right here, this is a table from Department of Health from earlier 2019, I believe. And this shows just mental health and substance abuse funding in general. So the community mental health centers are included in this. They're not obviously the total expenditures from the general fund. As you can see, our contracts for 2019, 2020 total, I believe, just over $100 million, and there's $168 million in that fund. So there's other programs there. But what I wanted to overall highlight is back in 2005, there was some big investments here and here, and then in 2009, and then you can kind of see from 2011 moving down that has dropped. And I also wanted to point out these federal funds, some of these are block grant money, which come directly to the centers, matched with state dollars to provide treatment. Some of them are special grant programs like the SOAR grant or the STR grant, as it was previously known, and that's specific to opioid treatment, medication-assisted therapy, things along those lines. So with that, I would stop and pause for any questions that the committee might have of us at this time.
Before we get to questions, real quick, Andy, I just want the committee to know that I forwarded that report that had those tables in it to staff and asked them to forward it to the entire subcommittee. I got that memo from Paul Demple. Representative Larson, please.
Thank you, Mr. Chairman. Andy, you made a comment that you're evaluating and making recommendations back to CMS and to the state Medicaid. But the reality of the situation, I just want to make sure we're on the same page and understanding, is Medicaid they don't give guidance, they make the rules.
Right.
And so as much as we may like to suggest that we love these new programs as much and that you're actively working on that, we're going to have to comply with what they allow. And we've no indication. I appreciate the fact that you're saying that we're going to tell them that we like what they've done for various things, but at the end of the day, they're going to make a decision and we'll have to comply. Is that a fair statement?
Mr. Chairman, Co-Chairman Larson, that is absolutely a fair statement and a good understanding of kind of the playing field involved with Medicaid and Medicare.
Other questions? Senator Schuler. Is that Rock Springs in the background?
Actually, no, that's the Tetons, just a little bit north of me. I would like to say the UNAs, but no, I don't have a good picture of the UNAs. Thank you, Mr. Chairman. Just a question for Andy on, I kind of wanted to go back to the ASI situation. I know that that's been kind of a problem in the past. I'm wondering if all the community health centers right now are using that electronic version of the ASI, and if not, maybe why not? And second, are we getting the cooperation that we need from the DOC to the community health centers in terms of not having to have people test and retest with the same situation? So if you can answer that for me, I'd appreciate it. Thank you.
Mr. Co-Chairman, Senator Schuler, yes, overall question, I think that it's moving in a good direction. So most of the centers used electronic ASI. So they buy a package of tests from a vendor and then utilize those either on a yearly subscription base or they'll buy like 5,000 tests at a time and then kind of run through those. There were some that were still doing paper to pencil. Sometimes that works better for a client, things along those lines. But with this program, we confirmed just a couple of weeks ago, all of the community mental health centers are now signed on for these electronic ASIs specific to the DOC probation parole population. They see the value in it, and we think it's a good step forward in terms of getting everybody kind of on the same playing field. And as Mr. Diamora stated, getting that accessibility so that if they move from Casper to Gillette and they go to another community mental health center, that that community mental health center will have quick access to it. I don't want to paint the picture that the community mental health centers weren't getting information from DOC or from each other in the past, but transferring records right now is not always the easiest thing with everybody on different electronic health records and with all the HIPAA rules and compliance. So we see this as a good, I don't want to say pilot project, but I think this will be a good step forward to addressing some of those concerns. And then the other thing that I can notate about the ASI is we are receiving funding through this subaward to pay for this first year of electronic ASIs. We'll need to look at how to fund that going forward, because this is just a 1-year funding allocation.
Thank you. We're at 11.5 minutes on Andy's presentation. Other questions for? Then I just would add this, Andy, this is a subcommittee, so we don't have the authority necessarily to write legislation. That would have to come out of appropriations or labor health, and appropriations were just money. Labor health, the kind of legislation that you're talking about. Here's my notes.
Mr. Chairman,
The parity bill. Yeah.
I don't know if it's being received by everyone else in the committee, but your microphone seems to have broken up pretty severely, and it's really difficult to understand what you're saying. Just FYI.
Oh, well, wonderful. Okay.
I don't know what you just did, but that seemed to maybe have corrected it.
All right, we'll try it the old-fashioned way. Can you hear me now?
We can.
Yes.
Okay. So the parity, I'm going to set mental health parity aside. I don't want to confuse that with these other issues. Getting private insurers to cover, that's going to be that's something that you should take up with Sue Wilson. Medicaid, legislation that says if the feds authorize it, we authorize it, including audio only. Those are all things that are going to have to be not requiring an inpatient visit prior to MAP. That's kind of stuff that if the Department of Health can't do it, it's going to require legislation. So, and those are things that are worth pursuing. I'll be interested to see what the Department of Health says they can or cannot do. They can't. I don't know that they can do anything for private insurers, though. That's something you're going to have legislation out of us. Isn't that right, Representative Wilson? You agree with that?
Mr. Chairman, we have the bill already drafted, and it was ready to go at any time that there was a special session, or failing that, the 21 session.
Okay, super. Wow, you're ahead of us. Thank you. And Representative Barlow.
Mr. Chairman, I've had to step away a couple times for that call that I mentioned to you before, but there's also another option within Medicaid, and that's an adult mental health waiver that Wyoming is not partaken in. And so that's another item that, at least when Department of Health gets here, maybe we ask them to give us a little more background on that. We heard about it in our first meeting as well, but you were mentioning the Medicaid component, and there is another option there as well that could be explored. Thank you, Mr. Chairman.
Thank you. Anything else for Andy? Thanks, Andy. Appreciate it.
Thank you, Mr. Chairman.
Paul Demple, Northern Wyoming Mental Health.
Can you hear me? Okay.
We can.
Thank you, Mr. Chairman, committee members. I'll be brief. I know time is short. I'm going to share my screen real quick to give you a breakdown in terms of Northern's criminally involved folks, how our clients break out, which I think will be useful. And there's one specific subset of clients I want to make sure we don't forget about as we're looking forward. And then I wrote down some things to answer some of the specific questions that folks were asking. So you should see a chart, I hope. Is that, you can see it? Okay. I did this on June 4th for the Judiciary Committee, and it's a real quick slide. Through FY20, we've so far for Northern Wyoming over our 4 counties served 1,436 people. And then the question becomes, how many of those folks are involved with criminal justice? And broken down by, on the left side is mental health, on the right hand is substance abuse, and by category. And so those folks that were actually on probation, those folks that were on parole, and then this red slide, that's the cases that I think we need to give some thought to, and I'll explain why in a second. out of all of our clients, 57% of our clients have involvement with DOC or criminal justice in some way, right? And that's the breakdown of all clients. If you go to mental health, well, 71% don't have any, and 29% have some involvement. And I'll send this out to folks too. I'll get it so everybody gets it. So then what happens when I get to substance abuse clients? 97% of the folks we treated through this fiscal year had some level of involvement. And I know that's higher than what David presented when he was saying 50 to 70%. I think the answer to that is in this area of criminal justice involvement. And unless somebody wants that, I'll stop sharing now. And what I did was I went in and said, where did the referrals come from? So we have this whole slice of folks that aren't on probation. They aren't on parole, but you know, they're on their second DUI or there's something like that, and they've not been on probation. They're in the court system in some way. And so they don't get tagged as on probation or on parole, but they're in the front loading in the system. And we're doing a lot of work with those guys. So as we're moving forward on targeting or looking at populations, I think if we just had anybody on probation or anybody who's on parole and left it at that, then there's this whole folks that are somewhere in the system that we can intervene with earlier. And so we need to probably have a discussion about that to make sure we don't drop folks, because I would suspect if we did, you're going to see a spike in those folks that end up back in the system. Jail-based IOP representative or co-chairman Larson. Northern is one of the 4 groups that is doing the jail-based IOP, and that's the contract with DOC. And so DOC has a contract with the jail, and they have a contract with the mental health substance abuse center to provide these services, and then they bring folks in. We just got started on that. Everything was coming together in February, and we all know what happened in March. And so things really got kind of clogged up in terms of transferring prisoners, but we were set to go and still are. At this point, I don't know whether they're going to continue to fund that. I'm waiting to see what the governor decides on the DOC cuts. And my hope is that'll continue, but I don't know. It could be if they don't cut that, we're going to move forward with it. If that's one of the areas they need to take away to try to balance things out, then obviously that goes away, but I don't have any idea. Telehealth capabilities, Representative Wilson was dead on. Generally, mostly our stuff is not people having phones and computers. It's mostly broadband and the broadband width, trying to do it in Upton and even other places in Crook County. The jail capabilities, that was limited. I think they may be getting up to speed. Part of what they're trying to figure out is make sure that when they're doing the telehealth and they're trying to respect the privacy, that the prisoner doesn't have the capability to get elsewhere on the internet. There's also that subset of sex offenders who are court ordered not to be have any technology and on the internet, but that's a subset, and it's small enough that I don't think you design a system around that. You have to find some workarounds. And the reassessments and portability. I think that depending on the practitioners, and I think that has been some issues sometimes, but I wouldn't say it was across the board. Everybody all the time didn't accept an ASI. And let me clarify this too. It's really not the ASI. The ASI is just a tool that the client fills out. It's the ASI, and then all the criminal history and everything has to be taken into account, and then a clinical interview that's combined, because the ASI actually is self-filled out by the client, so it's more than that. I think that I really appreciate David's comments about regardless of licensure and everything, we got to have some consistency in training and say, okay, everybody, these are the elements in an assessment. Here's, you got to use these things. And so you're going to get a higher inter-rater reliability, if you will, on those assessments. And I don't know therapists that I know personally have any problem taking a ASAM level is what it is, you know, the ASAM placement level that's less than 6 months old, because it saves me work and time. And we take them in and say they're supposed to come into medium intensity group or something. You put them in there, and if it quickly becomes apparent they need more or less, you just move them to that other level of care. So the fluidity and levels of care, I think, regardless of where a person comes in, if you're constantly assessing it, you can move up or down. So that's kind of a reason and support for accept them within the 6 months, I think. And I think that was it.
Okay. Can you hear me okay?
Mm-hmm.
All right. Questions for Paul? Well, it must have been very thorough, Mr. Demple.
Yeah, I doubt it. Anyway.
Any questions for Paul? Representative Larson.
Thank you, Mr. Chairman. Paul, and we've heard from several people, and I've just asked the question once, and so this consistency or standardization on the ASI or the process for getting that assessed. I think we've been having that discussion in getting those, trying to look at my notes here on how we do those assessments standardized and getting that done. Do you see that as being problematic?
Mr. Chairman?
Please.
Chairman Larson, I'm not sure what you mean by problematic, but I think it can be done. It sounds like they're going to do some of this stuff via telehealth. I'm all for it. I think it's a good thing. And it's not just the ASI, it's people have to be trained to ask the right questions and to develop the report. The other area that has been problematic, and I don't know what you do about this, is I have to actually in one county send a person to the county attorney's office to look through to get the legal history, and we can't take anything out. We have to write it all down. We have to, so getting that legal history is probably one of the most important elements, and I think that's probably hit and miss. I don't know how you deal with that with the different counties, but that's a big deal.
Thank you. Thank you, Mr. Chairman. And you did answer my question.
Thank you. Other questions for Mr. Demple?
Mr. Chairman, this is John Brody. Just a quick question for Mr.
John.
Demple. We have your presentation that you provided to the Joint Judiciary Committee. Is that the same presentation that you provided today?
I hope so, yeah. If you have it, yeah, you can send it the one with the charts.
Yeah. I just wanted to make sure that we can just send that on to the committee, and then
Oh,
we
yeah.
won't need to follow up on that.
No,
Thank you, Mr.
sure,
Chairman.
thank you.
Okay. Nothing more for Paul. I think what I'd like to do with the committee's permission is I'd like to circle back to David and Stephanie and see if they have any reaction or thoughts after hearing from those three folks. Representative Wilson, I saw you nodding your head. Is that something you think would be helpful? Okay. All right. So Stephanie, David, you heard three different folks with a lot of background, a lot of expertise. Anything there that you care to remark upon, follow up on?
Can you hear me, Mr. Chairman?
I can.
I'm afraid I cannot control my video. I think it may be control. Oh, there we go. I've just been given permission. There we go. I certainly agree with both Mr. Demple and with Andy Somerville in terms of their comments about the importance of training, the importance of the interview being clinical, as Paul indicated, the ASI is one piece of the tool in terms of the overall assessment and determination of the ASAM level, but it is an important one. And it is true that our focus was not on private providers. So I certainly have no agreement or disagreement with what that provider was talking about. Our focus, given the nature of justice reinvestment, has been on the governmental agencies and those agencies that are funded by the state. So indeed, in our looking at the issue of the quality assurance unit within DOC and looking specifically at the criminal justice clients, our current focus has been to assure that that works well with all of the community mental health centers, because that is where the majority of the clients do reside. Having said that, it may be that as DOC moves forward in the development of this, that they will have a subset or a subgrouping in terms of how they will look at quality assurance issues for those clients being seen by private providers, but that's beyond the scope of our technical assistance in what we're able to provide. Other than that, as always, as I said before, you do have a good number of really good clinical folks there, and that is nice. I don't see that everywhere that I go, to be very honest.
Thank you. Stephanie, did you have anything to add?
Nope, I think David did a great job of answering some of those questions that we kind of keyed up on from those past three presenters. Thank you, Mr. Chairman.
Okay, thank you. David, I'd ask something of you and Stephanie, and I want to follow on with something earlier when I said on slide 25, I felt you needed to add probation and parole judges and so forth. And you said, well, you know, good idea, but here's what we've got for the BJA grant. In your final report, might you add just, something at the end that says, here's a whole host of things that have come up that really need attention. It's just not within the scope of what we were hired to do. And the reason that I'm asking that is that whether it's you or some other organization, we might follow on for additional BJA grants to follow up on those things, or an additional follow-on CSG BJA grant. I just heard a whole host of these things. County attorney can't get the legal history. So I think those are all things that need to be, and Paul talked about he's used the word front loading. And so our focus has been on people coming out of prison. But, the 24/7, it's intended for the Monday morning conversation that somebody has that gets picked up for an alcohol or drug related offense, that Monday morning after they get out of the poke, it's the conversation they have with their attorney, where somebody like Jared Olson says, here's what you're going to do. You're going to get hooked up with mental health counseling now. We're going to get you tested twice a day now, so that by the time the disposition comes up and we're plea bargaining with the county attorney, you're clean, you're holding down a job, you're paying for your kids. And it's not happening in a lot of areas. It's still the same old justice system where, they start getting the help about the time they're coming up for sentencing and disposition 2 to 3 months after arrest. And by then they've been arrested for something else. So the timeliness of the intervention is rife throughout the entire system. And if you could make notes of those kinds of things, and maybe we have a subsequent conversation with you. What is phase 2 of your work? And how do we get a BJA grant for that?
Mr. Chairman, we're happy to do that. And indeed, in some of our previous presentations, we've added a section where we said something along the lines of, and here are some additional things we suggest that you look at. And we're certainly happy to do that as we put together the final report and additional information for you.
Thank you. Folks, committee members, subcommittee members, anything else for David or Stephanie before we move on to agenda item 3? No? All right. And David and Stephanie, are you still going to be here for the balance of the day, or are you done?
Mr. Chairman, I will be here for about another hour or so, and then I have another commitment.
Okay. Stephanie, same?
Same.
Okay. All right. Well, thank you both. So with that, let's move on to agenda item 3, overview of MHSA services through the criminal justice system. That's Department of Corrections, Department of Health. And that's an agenda item there. So we were originally scheduled to start that at 10. We're about 50 minutes behind, but that's not too bad as things go. So we have, they're admitting now Department of Corrections and Department of Health. My agenda does not have who the presenters are for each of these items. So Stefan, Dan, Don. Okay, who's leading off? Okay, Stefan leads with Don in the batter's circle.
Thank you, Mr. Chairman, and good morning to the members of the committee. I am joined by my colleagues at Department of Corrections, Deputy Director Dan Shannon and Don Sides. I'll share a screen for our joint presentation on this topic. Give me 1 second. And let me know when you're able to see it.
I can see it.
Okay, very good, Mr. Chairman. So just a few brief comments from the Department of Health, and then I will kick it over to our colleagues at Department of Corrections on some updates that were requested by the committee. You had asked for the Department of Health to provide an update on the House Bill 31 bill that had passed in the previous session, and we'll certainly do that in a bit more detail. I wanted to just briefly provide the committee with some key takeaways from the analysis that the Department of Health performed in conjunction with the Council of State Governments. I won't spend a whole lot of time on this, Mr. Chairman, as David and Stephanie did allude to much of this detail. But just very briefly, the Department of Health did assist the Council of State Governments, as was mentioned, with the data analysis and modeling between Department of Health data and Department of Corrections data. And essentially, just to give the committee a bit of a refresher, the data from Department of Corrections and Health was merged. And essentially what we did is we looked at all of the Department of Corrections clients that were discharging from the corrections system on supervision and parole who had a criminogenic risk score from corrections and an identified need or a flag for mental health, substance abuse, or both. And so that's essentially what was analyzed. And as was mentioned, what we found was approximately 50% of those clients leaving the walls of the correction system at some point in that 5-year period that we analyzed. 50% of those discharging on supervision or parole sought care at a community mental health or substance abuse center. So what we did with those clients that were merged that we could find, leaving corrections, but also showing up in the Department of Health records at the community mental health and substance abuse centers, we performed what's called an accelerated failure time analysis to look at, to be able to model recidivism from the community back to corrections based on different variables. And what we found was for those DOC, Department of Corrections clients who had high criminogenic risk scores and a mental health or substance abuse need, that receiving care at a community mental health or substance abuse center was associated with an increased length of stay in the community. For the lower risk clients, those who had a lower criminogenic risk score, I believe that assessment is called the COMPASS, there was a less apparent impact in the analysis and in the model. I want to be clear here that the results from the analysis that we performed, they show a correlation, but certainly not causation. So again, without doing or implementing a randomized controlled trial where you would assign some of these clients into a new program with mental health and substance abuse treatment and others not, there's really no way to start to demonstrate causation. But we did see a correlated impact in basically less recidivism or a longer time before recidivism happened for clients with high risk scores and who received care at a community mental health and substance abuse center. So on the next slide, Mr. Chairman, on slide 3, you'll see the results of that analysis and that model. So essentially, you can see on the axes here your low and medium and high risk score clients, and then on the right side, substance abuse only, mental health only, and then both mental health and substance abuse. And then on the left side, the left axis, you can see the survival probability. And essentially what that means is, not to be particularly crass with these terms, it's really just the analytical terms. You look at a time to failure. It's very similar to doing a death rate analysis, but the failure that we're looking at is essentially a client leaving the community and going back into jail or prison. So essentially having their supervision or parole revoked. And what I want to point out again, as David alluded to briefly earlier, where we really saw impact in the analysis and in the model, and some correlation between services and recidivism, was with your higher risk score clients. So if you look at the mental health and substance abuse both mental health and substance abuse flags. So a client essentially leaving corrections that has mental health and substance abuse needs, or it's part of their probation or supervision. You can see those two categories at the bottom right-hand side, and a much larger delta between those that received services, those that did not receive services, and their subsequent time to failure on the bottom axis there. So that's really, again, as I've said before to the Labor Health Committee and to others on this topic, where we see impact is really in the prioritization area. So if again, the theory here would be if you prioritize the clients with the highest risk score, the highest needs, that's potentially where you see the reduced recidivism. And ultimately, Mr. Chairman, the goal of this project with House Bill 31 and what was essentially developed and put into implementation with the Judiciary Committee, with the Council of State Governments, and with the Labor Committee bill, the ultimate goal is to reduce recidivism and thus reduce cost in the Department of Corrections for essentially contracting for out-of-state beds when the prisons and jails are full here in Wyoming. So where you really see that potential return on investment in this model is in investing in mental health and substance abuse services for that higher risk category.
Representative Wilson.
Thank you, Mr. Chairman. Good job noticing my hand. I have a question actually on this particular slide, because I was looking at the two starred ones and I'm like, okay, great. The impact of services and looks good. But I'm wondering though, then I also looked up at the high risk substance abuse only, or well, either any of the risks, but the people who perhaps don't even have a mental health. I mean, it almost looks like the ones without the stars show that unless you have both problems, you're doomed. I mean, that sounds terrible, but the difference between the received services and did not receive services, like if you only have a substance abuse problem, it doesn't really seem like the services actually help you, and maybe the mental health as well. I mean, both of them, the end over time ends up with only a 25% survivability anyway. How can that be? I mean, I guess I'm not sure if I'm as happy about the charts as I thought I was going to be. What does it say that people, what does it say that people with only one problem don't seem to be helped over time? Am I reading that wrong?
Mr. Chairman, if I may, Representative Wilson, no, that's not the correct way to read this chart. The idea here is we're not measuring quality of service or impact to the person's life. What's being measured here is just those who left corrections and either did or did not receive care at a community mental health or substance abuse center, and then their associated modeled out simulated recidivism time. So in terms to say that, any of the clients that would be in the categories on this chart, didn't receive good care or weren't helped, that's really not what's being measured here. It truly is a time to failure analysis specifically tailored to recidivism back into corrections and its subsequent association with whether that client received care at a community mental health or substance abuse center. So no comment here on the quality of service. Again, as we mentioned before, about half of the clients that leave corrections with a mental health substance abuse flag do not receive services at a community mental health or substance abuse center. There's probably a variety of reasons for that, including clients that might receive services from a private provider or a non-community mental health or substance abuse center that's funded by the department, or leaving the state. I mean, there's a variety of reasons why only about half are captured in the community mental health and substance abuse system. But to be clear, again, this model shows the correlation between receiving services at a community mental health and substance abuse center and the time, basically the time in the community before recidivizing, if I can invent a word there, back to the correction system.
Anyone else? Okay, so before you go on, Stefan, I'm going to ask you, because you talked about 50% sought care, and so somehow we've got to reconcile this data back to what CSG had, which is additional 305 days. And then, you know, if 50% come out and they're ordered to go get care and they're not going to the mental health center, I think we heard Paul Demple say, no, they're coming here. They're not showing up in all the data that CSG had, but they're coming here with very rare exception. So how is it that you have a 50% number? And I don't want you to answer that now. I'm just asking that you work with the community mental health centers trying to identify what the deficiency is in the data, because I'm with Representative Wilson. I mean, that bottom right-hand chart is stunning if I'm reading it right. 1440 months is almost 4 years. So if you receive both MH and SA, you know, you're out for it's 50% probability you're going to be in the community for 4 years, which essentially means you're off your probation or your parole. And I mean, 4 years is a good long time versus 23% probability you'll stay out for 4 years. That's, you know, it's more than double the success rate. People who receive no services. So we really want to know that this data is accurate. Thank you. I'm sorry for that. Go ahead with your presentation.
No problem, Mr. Chairman. I will say this is the data that CSG did use, so it's all the same. I will just mention, Mr. Chairman, that the denominators are different between this in terms of all clients that leave Department of Corrections and the denominator of what you saw from the Community Mental Health Center, and specifically Northern, where yes, I'm sure 90+% of their clients on the substance abuse side have some corrections involvement, but that doesn't directly correspond to this data coming from Department of Corrections, where all of the clients leaving the Department of Corrections might not receive care at a community mental health or substance abuse center. So again, no value judgment there, no quality or performance judgment, just a different population. Moving on, Mr. Chairman, I'll be very brief here and then hand it over to Deputy Director Shannon from the Department of Corrections. The committee had asked for updates on House Bill 31 from the Department's of Health side, specifically the contract additions for this next fiscal year as it relates to Department of Corrections populations. Those populations have been added to our mental health and substance abuse contracts with the community mental health and substance abuse centers as targeted populations. And you can see the contract language here that both includes probationees and parolees. I'm happy to answer any questions about those contract mechanisms, but we did go over that in the first meeting with this committee. But I'm happy to stand for questions there, or can go ahead, Mr. Chairman, and kick it to Deputy Director Shannon to go through the Department of Corrections updates on House Bill 31.
Any questions before it gets kicked to Shannon? Okay, you're up.
Thank you, Mr. Chairman, Co-Chairman Larson, committee members. I'm Dan Shannon, Deputy Director for the Department of Corrections, and also with me is Administrator over Field Services, Dawn Sides. With your prior presentation from Mr. Demore, I tried to take some notes and maybe I'll answer a few questions and then I'll get right into Deputy Johansson's presentation. I want to thank Dave and GS staff for the updated information. I certainly appreciate their guidance between R3 through Department of Health, CSG. It's my firm belief. I think one of the questions that are being asked, are we creating the right framework and groundwork under House Bill 31 for the potential efficiencies and streamlining to reduce our recidivism rates? Our current population on probation and parole on in-state presently at this time is 6,120. 75% of that population indicates a high probable or probable need for substance abuse, while 3,504 are in treatment, completed, or have been referred. We currently have 919 that are in review or are waiting some form of treatment. Success rates beginning July 1st, I went back to one question was asked between 2009 and this past week, are indicating an increased success rate to our actual revocations was 361 with 193, Mr. Chairman, that was direct result of substance abuse compared to the previous year, which was 481 revocations with 314 directly to substance abuse. But there are many factors, and it also, we're waiting to see how this COVID pandemic with our over supervision will pan out. As all of you are aware, or many of you are aware, we have all our out-of-state inmates return now back to our facilities. Our present current population is 2301. Representative Wilson raised the question regarding telehealth. Since our Judiciary Committee, Department of Corrections has submitted application through CARES Act for updated telehealth equipment inside our facilities. That's been completed. Mr. Demple raised a question regarding cutting budgets, and I can tell you that all items are being reviewed. There's been no decisions made, but we are taking a pretty straightforward stance. What can we do to still continue to produce the best product and reduce inmates returning? So that means education and treatment are our highest priorities. As Deputy Director Johansson indicated, we worked together on this slide, and I'll present that soon. Mr. Chairman, I've been kind of overwhelmed with COVID and our budget crisis, so there's maybe questions I don't have, but I will respond to you in a timely manner. The Department of now onto the slide. The Department of Justice subawards being prepared and allowed for the following. This under number one, the Assistance and Development of Quality Assurance Unit is really our foundations. Under the subaward, we're working with ACJI. It's a group. It's out of Colorado. For this criterion, selecting clinicians, as I believe Stephanie indicated, that should be completed by October of this year. And we believe this funding and this selection we should be able to bring on 2 clinicians to assist with this, with the funding that was provided, as indicated through CSG. And assistance in the development of responsibilities within the audit responsibilities and the instrument and the matrix. The WDSC also purchased 4,000 online substance abuse assessments for community providers, prison substance abuse contractors, AOAA, and clinicians. Policies and coordination of cases will be audited and mechanism for the report. Deputy, can you go to the next slide? As far as our ASAM criteria skill building training, this training is really established from a company called Train the Change. It will assist identifying the criminal elements that was a key factor in the previous discussions, considering the ASAM's effectiveness on criminogenic needs, and it'll also bring Department of Health and Department of Justice together on a similar mission in the way we look at it. We may look at our overall goal, I believe, is the same. Externally, though, we may come from a different viewpoint from Corrections and Department of Health, and I really believe that training will take place. As far as a structured decision tool making for treatment, includes information towards our ASI, ASAMs, and use of risk needs to dominate the appropriate placement. This matrix, which really involves up to 80 hours of preparation and time, will incorporate decisions regarding identification, treatment levels, and offender risk, and as well as concerns for treatment. And I know this was raised by Miss Andy Somerville today. And third, the Leadership Development and Culture Academy within Wyoming Department of Corrections and the Department of Health. This, because of COVID, has now become a virtual training. It's to be completed by February, I believe, of 21, and will prove collaboration between the 2 agencies. And it'll go back to similar to what I said, to reach us with the same goal as far as the outpatient. Deputy? Weekly meetings continue to occur. Most are led by Dave with CSG, Department of Health, Council of State Government. We're going over the sub-award training opportunities and building a communication platform on the issues that are brought forward on that. There's so many difficulties with the external proprietary databases, and that's really what we're focused on now. As mentioned earlier, Executive Director Andy Somerville is now participating as a liaison, and we're meeting with WISAC. It's scheduled now for July 10th. There are some obstacles, Deputy, if we can go to the next slide. Access to possession of treatment-related data. As it was brought up by several members today, there are many difficulties. The databases, many are proprietary. We're also challenged by the oversight of 42 CFR on how we can bring this into one database. I know we're working very diligently, even with our statistician here, and to see how if we can come up with some type of coding to bring everyone together with that. Number 2, audit data repository and outcome reporting platform needs established. We need to develop a reporting mechanism that will benefit the offenders as well as a current and accurate data. Without that accurate data, we're kind of spinning our wheels and everyone's drawing from their own. We heard today that there's different forms of funding cost. There's different forms of the way the ASIs are being presented or the history and the way that they're being presented are producing different outcomes. And so to us, that's one of the keys to establish that data in that database. Last section of that, the Department of Health and DOC has been managing through COVID-19. It has slowed the development of the competitive-based funding, as with everything, but we are moving forward. I feel very comfortable reporting to the committee members that both agencies are working together collaboratively. We're working together and we are moving forward. And that will continue, Mr. Chairman, throughout our next fiscal year. Deputy Johansson, you want to take it up?
Mr. Chairman, thank you, Dan.
Representative Wilson, let me interrupt just a moment. Representative Wilson, please.
Thank you, Mr. Chairman. I did just have a brief question for Deputy Shannon, and I think this population might not be a very big part, and it's not really your responsibility. But it seems like reading the paper that the feds are having a lot more involvement in, some of the DEA type, the various drug cases and stuff that you see. And so I would suppose that if people, go into the federal system, if they're a Wyoming person, then they're still released out into the community eventually from that. Are you able to track those people at all? And is that a very small percentage? I mean, 5% or something of the criminal issues? Or do you have any thoughts on that?
Mr. Chairman, Representative Wilson, I'm unsure of the exact number of the percentage of how many individuals that would be, but I can obtain that information and get it to you. And no, we do not track. We do not track that outcome through the federal system. Did that answer your question, Mr. Chairman, Representative Wilson? Did that answer your question?
Mr. Chairman,
no,
just as a follow-up.
It's a fantastic question.
Yeah. So just as a follow-up, Mr. Chairman, that I think, obviously, if it's only 2% of the criminal corrections type people, then I'm not saying that we don't want to care about anybody, but if it's in the couple of hundreds, we maybe just need to have some other little loop to kind of capture that component too. Anyway, that's all I have on that, Mr. Chairman.
No, it's a good question. Thank you. So it went from Dan football back to Stefan. And Stefan, what were you going to say?
Thank you, Mr. Chairman. Just in closing, I'll agree with Deputy Director Shannon. I think the work has been very successful, especially on the majority of what was included in House Bill 31 with the collaboration pieces between the two departments. As you see on the last bullet point here, the one full disclosure we wanted to make, there was a very specific part of the bill that directed the development of a separate and competitive outcomes-based funding stream for corrections clients, which really is, again, kind of the microcosm of what we've been talking about with the community mental health system and the decision points around prioritizing certain clients. Again, that work will continue. It was slowed in its development due to the pandemic, and also recently with the budget reductions that are being that we're being required to develop. All of these, any new program elements are certainly, I won't say at risk, but we have to consider that in light of our funding situation. So as we discussed with the Labor Committee over the previous interim, when it comes to this type of program for an outcomes base or incentive payment for getting better outcomes for corrections clients in the community system, that investing in that either requires additional money or requires the reallocation of current money. And again, within the budget and revenue context that we're currently living through, there's just some caveats there. So we wanted to be upfront and clear with the committee on that. But Mr. Chairman, that concludes our presentation. I'm happy to answer some of the questions that were noted by LSO and directed to the department in the earlier presentations by Council of State Governments and the other presenters, but I'll leave that to your discretion, Mr. Chairman.
Well, I think we want to go ahead and get a follow-up on those items. Before you leave this presentation, though, on the sub-grant, that's not what you called it. You called it a Justice Reinvestment Sub-Award. How much is that? Maybe you said it and I missed it. How much is that for, and when do you anticipate getting it, and what's your timeline here, basically?
Deputy Shannon, do you want to take that one?
Yes, sir. If you could bear with me, I do have, Mr. Chairman, I do have that information. Administrator Sides, do you have that information available?
Yes, I do. Chairman Kinski, the sub-award is about a month away based on what David had to say from CSG, and it's approximately around 120,000 that will cover all the what we need with all of the training, equipment, the ASIs. It's right around 120,000. But we can't purchase anything or roll any of this training out until the sub-award is granted.
All right, thank you. Okay, Stefan, go ahead and proceed with the follow-up on the questions that arose in the course of the CSG presentation.
Thank you, Mr. Chairman. I noted about 4 questions, and I'm happy to go into more detail if the committee needs. The first one was, did the Department of Health back in the 2015, 2016 period pay for our Title 25 cost overrun with mental health and substance abuse dollars? The answer to that is no. We funded that with, for as long as we could, with unspent money in the department that was obligated in other areas, but would have been potentially reverted. The subsequent biennium going into 2017, 2018, following that era of sort of Title 25 cost increases, we did implement budget reductions across the department to the tune of over $100 million. So that's potentially where some of that confusion was coming from, but we did not move mental health substance abuse treatment dollars over to the state hospital budget to pay for Title 25 when we did have that cost overrun. The second question that I have noted here, Mr. Chairman.
Representative Larson had something on that for you.
Thank you, Mr. Chairman. Stefan, so could you just take a minute on that funding issue that we talked about? And so what we heard from some of the testimony is that we've had reductions to the community mental health centers. But it appears to me that that's not in general funds. That may, but overall, if there were the reductions, and if there was, how was it determined that those were implemented?
Mr. Chairman, Co-Chairman Larson, good question. So back when we prepared budget reductions for the 2017-2018 biennium, the treatment units, as we call them, across the community mental health and substance abuse programs were in fact reduced. It was about an 8.3% reduction to the overall budgets in that unit, or across those units. So mental health outpatient, residential, substance abuse outpatient, and residential. which totaled, if memory serves, and I can get you the exact details, it was a little over $8 million, as I recall. So we implemented those in terms of contract reductions with our community mental health and substance abuse centers at the beginning of the fiscal year for fiscal year 17. Fast forward about 6 months, and the legislature met to consider, debate, ratify, or change all departments' budget reductions that had been implemented during the interim period. And the JAC and the legislature, in fact, did add money back to mental health residential, mental health outpatient. And so the effective cut in general funds for the 2017-2018 biennium, as I recall, was around 4% for those areas. And there's a variety of reasons why you see kind of a different story when you look across all of the general fund and all of the federal funds within that system. But Ms. Somerville's testimony was pretty accurate in that the general fund has been relatively flat with a little bit of a dip during that fiscal year 17 period. The federal funds and tobacco funds you see in that system, we have been able to leverage more of those, but that's not necessarily equally distributed across the centers. It can be for certain grants or certain programs that we were able to get federal or funds or use and leverage tobacco settlement funds. But happy to provide the full budget detail over each fiscal year for those. But there were certainly budget reductions. Just some of those over the years since they were implemented have been added back or added through other funding sources.
Okay,
So
that was number two. Yes, please.
Follow, Mr. Chairman. So Stefan, when we heard testimony that budget reductions took place, your point is that did happen in the 17-18, but those reductions have since been replaced. Again, am I correct in understanding that?
Mr. Chairman and Co-Chairman Larson, yes and no. I would say some of those cuts have been replaced. It's just not a one-to-one with, 8 million was cut and 8 million was added back. It really depends on the center. It depends on various grants that were used. But yes, it is accurate to say that the budgets for those units were in fact reduced for the 2017-2018 biennium. But again, happy to provide that level of detail to the committee.
Very good. Thanks, Stefan. Thank you, Mr. Chairman.
Mr. Chairman.
Okay, Stefan, you had 4 follow-ups. We've gotten through 1 and 2. What's 3 and 4?
Very quickly, Mr. Chairman, number 3, you had asked on any latitude that's needed to continue telehealth reimbursement in the Department of Health. I'll answer initially. I don't see a major need for legislation here. There was one area that was brought up that I'll follow up with our Medicaid office on, specifically reimbursing for audio-only telehealth visits. And so we can follow up with the committee on that. But in general, and even prior to COVID-19, Medicaid has reimbursed for telehealth at parity with any other in-visit service. So it doesn't matter if the client is at their home and the provider is, at the office. The client doesn't have to go to a specific, place or provider to do a telehealth visit. So that reimbursement parity is there. There's no legislation needed to continue that, but we'll certainly follow up as one COVID-19 measure that we implemented was reimbursing on mental health visits for audio only. And I'll get the committee information on what the timeline is of when that would expire, for example, if the national public health emergency is rescinded. And that's just something we need to follow up on. So one caveat there, but in general, Mr. Chairman, no legislation needed on the department side to continue to allow and reimburse for telehealth visits on behavioral health. And finally, Mr. Chairman.
So from that, what I understood you to say is the department intends to continue even after the COVID crisis is passed with the current flexibility on telehealth and billing for video consulting rather than in person. Is that correct?
Mr. Chairman, yeah, there's no intention on the department side to remove that after COVID-19. It was in place prior to COVID-19, again, with the exception of the audio only, which I'll follow up on.
Okay, thank you.
And finally, Mr. Chairman, you had directed LSO or the department to gather all of the dates of various organizations, law enforcement, county officials, et cetera, to get time to talk about these issues. Just wanted to mention that last fall, I presented to the Wyoming Association of County Officials. I've been in touch with kind of an offshoot of the Judiciary Committee meetings from this year with a select group of the Association of County Attorneys who are discussing Title 25 issues, gatekeeping issues, behavioral health issues in general. So we're certainly plugged into those pipelines, but we'll make sure to double down on attending those meetings or requesting to attend those meetings, especially if there's relevant information from the department on areas that they're working on the legal, law enforcement, or any local community side. So that concludes my list, Mr. Chairman. I apologize if I missed something, but happy to stand for additional questions.
Anything further from the committee? Senator Schuler.
Thank you, Mr. Chairman. Just if I could ask a couple questions of Deputy Shannon. And one of them is just a clarification over on slide 8, and I may have misheard this, but I believe you were talking about the audit data repository, and you mentioned something about 42 CFR, which I have no idea what that is. If you could clarify that. And then secondly, you mentioned that we brought back all of our out-of-state prisoners. Was that because of COVID issues, or I'm just wondering if we've actually had a decrease in our prison population? Thank you, Mr. Chairman.
Mr. Chairman, Senator Schuler, thank you. 42 CFR is a federal oversight policy that really determines how it's actually stricter than we have our HIPAA laws, but it really provides on how data electronically can be transferred back and forth between agencies and providers. And it really restricts the guidelines that for we as a state agency to develop a database that everyone can draw from, or at least a baseline. We really have some tough guidelines. Concerning bringing our inmates back, no, our population hasn't dropped. We lost approximately 59 inmates with our good time jail bill effective July 1st. Our current population is 2108. I'm sorry, I gave the wrong. We were originally going to bring our inmates back at the conclusion of March of this year, but because of COVID, the inmates in Mississippi, as well as those in the females in Nebraska, we brought our females back. We are completely capacity at our women's center in Lusk, but our females are now housed at WMCI, which is compatible and set up for that. We brought those individuals back, and our individuals that were in Mississippi, we had those housed out for two reasons. One, short staffing as well as construction, and those kind of went together. And we are progressing very rapidly with that. Our inmates were brought back. We brought them back in segments of 2-week intervals. They were in isolation as well as we tested them for COVID. And then we got everyone returned. So to answer your question in summary, we brought those inmates back. We should have had them back in March if at all possible, but because of COVID, we could not. I hope that answered your questions, Senator Schuler.
How'd that do, Senator Schuler?
That was just fine. Thank you, Mr. Chairman.
Okay. Anybody else have anything? Well, I want to circle back to Stefan. So this is a subcommittee. The appropriators just deal with money, and we're under pressure to find 20 to 30% out of the state budget, as is the governor's office. We may not have to act if you take care of it all. But, and we see that the Health Labor Subcommittee's been doing some good work. And of course, there's been talk about maybe reducing expenditures by going to just priority populations to the community mental health center. So the interest in appropriations is that we don't do anything that's, really counterproductive. That we inadvertently say, for instance, if we didn't identify corrections populations as a priority, that would have some pretty severe implications for the entire criminal justice system, is what we've learned. But you are having discussions already with the community mental health centers and the mental health substance abuse budget. Can you give us just a thumbnail sketch on how that's coming along and what prospects that has to reduce expenditures for mental health and substance abuse?
Yeah, Mr. Chairman, very briefly on the budget reductions that have been directed and requested by the governor. We have developed those scenarios. Nothing's final yet, so I don't want to jump ahead of our chief executive who's reviewing all of our proposals right now, because any detail I gave you on those scenarios would not be final. But we have had to look across the entire enterprise, as you mentioned. We don't know yet what the final request as a percentage of our general fund budget will be for reducing, but we know it's going to be somewhere between, probably 7% and 20%, like you mentioned. I think that's a little bit fluid and evolving. But we've looked across the enterprise, including Medicaid, which represents the majority of the department's general fund budget, as well as our behavioral health programs, including our community mental health and substance abuse centers and our developmental preschools. Those three that I mentioned, as you've seen before, do represent a very, very large share of the department's general fund budget. So in cutting even a number like 10% of general fund, which is approximately $100 million for the department, we can't reduce budgets and hit that target without reducing those line items, unfortunately. So we've been in communication with our providers, with Ms. Somerville. I think everybody knows we're going to have to look at all areas of the department to reduce, but the specific numbers and the implementation dates are not yet final, Mr. Chairman.
What were the three, Stefan? Community centers, community mental health centers, child development center, and what was the third?
Yeah, Mr. Chairman, I'll give you five, actually, if you'll allow me, because these five line items
Please.
represent 91% of the department's general fund budget. And that's Medicaid, which includes our waiver programs. Mental health and substance abuse is number 2. Number 3 is developmental preschool, what we call EIEP. And then the remaining 2 are the state hospital and the Life Resource Center. Those 5 areas account for 91% of the department's general fund budget.
Okay. Anything else for Stefan before we go to public comment? All right. Thanks, Stefan. Thank you. Thanks, Don and Dan. So we have several people up. I'm going to take them in reverse order. I'm going to start with Paul Demple because I just left off talking about budget and the conversations between DOH and the mental health centers. And I think I'd like to, Paul probably has his own presentation. Do your presentation, but maybe then you can kind of follow up on the question I just put to Stefan.
Okay. Can you hear me?
We can.
Okay. I'll just keep it brief. I just wanted to comment on Chairman Larson's questions about the budget reductions. It's what the general contract dollars, like for Northern, are down from 2016-17, probably 230,000 or something. And what the system has done over time is the general contract says, all the people coming in and the general stuff. Where we've had increase in money is, say, from the SOAR grant, the state opioid response grants, where we developed a MAT program. We had some AOT money for the assisted outpatient treatment, the gatekeeping stuff, where they said, okay, we want you to do these special and specific things. And so what happens is we still do all the other things with the decreased general fund dollars for the general outpatient contracts. Then we got other dollars to shore up these other things, and those kind of come and go. So the other thing that's in there that doesn't get thrown in the equation very much, besides just the state general fund dollars, is the Medicaid rate cuts back then. Went from 87 to 83, so like a 5% cut, I think, and then the caps on the Medicaid services at 20, which they just recently in the last year increased to, I think, 30 visits, knowing that 20 was difficult. So that's the complicated picture of how the system has been addressing specific needs while the general contract dollars are actually down. And that's all I have. Looks like the chair's gone.
Representative Wilson.
Hear me on the phone?
Thank you, Mr. Co-Chairman. Paul, going back to Representative Larson's noticing of the contract money, you know, dipping down and then more or less being flat or roughly where it was. But I compare, for example, to like the school systems getting ECAs, you know, such that employees and whatnot get raises and that kind of thing. So in essence, being flat over 10 years, are you, so your providers that you're paying, whether on staff there or contract for like telepsych and all, I assume, are they getting paid the same that they were, say, 5 or 6 years ago? And are you having trouble recruiting providers? Is that hampering the access any?
Mr. Chairman.
Please.
Mr. Chairman, Representative Wilson, what's happened over time is that this whole system was built at a time when we didn't have computers, we didn't have data, we didn't have a lot of these things. And so what's happened over time is things have become more expensive. I didn't have, when I, 30 years ago, we had paper and pencil. Now we got software, we have computers, we have those, and we're seeing continued and increasing software costs that have become more and more critical for us. So that's one area that can be problematic, but I think every business has struggled with that. Obviously, having competitive wages, and I feel like we're pretty competitive, is important. But the expenses for the benefits, continue to go up, which is, I know, every business is dealing with those things. The overall flatness of, it's not just been the flatness of the state dollars, you also have a decrease years and years and years ago for the SPMI, seriously persistently mentally ill population. They were probably about 47% of those folks were on Medicaid. Right now, I think my last number I ran was 27%. So you have fewer folks on Medicaid than you did before. You have a decrease in funding there. So that's where you can take a hit. So it's across the board. One of the numbers that's probably the easiest is Clearback. This is many, many, many years ago. They had targeted dollars for seriously mentally ill, and we got some dollars, Northern did, to develop apartments, these 10 apartments. And the dollar amount given at that time was $266,500. And I'm talking, God, it's got to be 10 or 15 years ago at least. The amount of dollars I get for those is still $266,500. Actually, it's less than that because I took that cut back in 16, 17. So it's the combination of all of the, at every place we get dollars, it's been cut and limited. And so that's really the sad truth. I hope I answered your question.
Okay, so my question that I wanted to follow up on is I heard you talking about the cuts, but you're having conversations, we're under pressure to continue to cut, limit the services to priority populations. You're having conversations with the Department of Health. Stefan didn't want to give us a whole lot of detail on that, but just you're in conversation. Is that all we know?
We are, I feel confident in determining a path forward. You know, I'll know when everybody else knows what the actual cuts are. But in terms of moving forward from what the system has been over time, developed years and years ago as a community mental health center system, take everybody comes in, sliding fee scale, moving towards the new realities that the conversations I've had with the Department of Health, I am optimistic that we're going to be able to sit down, given whatever the final dollars are, and try to come up with, as I call it, the best worst case scenario on responding to those budget reductions. But there's going to be a reality at the end of the day that is going to have to be addressed about who can we afford, and the likelihood without, and there's not going to be any new money in the system, there's going to be some people that get services and some that probably don't. You know, I just, not
Gotcha.
what anybody wants, but it's our reality.
Gotcha. Thank you for that. Anything else, Paul? Anything else from the committee for Paul before I call up Andy Somerville? Mr. Demple, please.
One thing I'll tell you, and the staff knows now, in preparation for our cuts, and I'll be interested to see how some other centers have adjusted to the upcoming and anticipated cuts, that I had several positions that we were trying to fill. So any open positions in the new budget year I cut. I laid off 3 folks, had to cut back pretty severely on psychiatric. I had a APRN who was an employee, worked full time. What I can afford now is I've cut that, and I'm going to contract at $150 an hour for 12 hours a week. My guess is, I think I don't know what the system looks like now with the cuts. That's going to be important. But that's an honest, and with that, I'm still anticipating about $200,000 shortfall next year. But I can't, I mean, you can cut and cut until you kill the patient, right? So we're hoping some things turn around and whatnot. But that's just the realities that everybody's dealing with. So I don't want to bellyache.
Okay. Well, thank you. Appreciate it.
Mm-hmm.
Andy Somerville. Welcome back.
Thank you, Mr. Chairman. Again, Andy Somerville representing WAMSAC. And I just have a very couple of few brief comments because Mr. Demple covered everything pretty well, as did DOH and DOC. I just want to highlight, we spoke on the previous item about that criminal justice population that's not on probation and not on parole. As we look at priority populations and funding, we need to keep that in mind. Because they're not necessarily in the purview of DOC as we look at targeted populations and priority populations. We need to keep a mind on how that population will be affected. Just as you can see from Paul's numbers, that is a pretty decent percentage of the clients that are involved in his system right now. And that number is similar across most of the centers. As far as budgets and contracts, just to highlight again, the contracts being flat has really put a squeeze on a lot of the areas for the centers. So Representative Wilson, your question about salary, right now our community mental health centers are not competitive with private providers. They try to be as competitive as they can, but right now their salaries are not competitive with an LPC that's a private provider that has a thriving practice. They're not competitive with a lot of the salaries up at the state hospital. If you ask my center in the southwest corner of the state about trying to retain their providers, it's really difficult right now. We're not very competitive with some of the federal facilities like the VA facilities. So that is a constant struggle. But Mr. Demple did highlight, how those increasing costs, both in technology and how business practices have changed. I mean, everything has kind of put a squeeze on it. So I think his comments were very representative of the entire system. And then last is just moving forward on these conversations in regards to priority populations, how we handle budget cuts, who we get services. We have been in contact with the Department of Health. We're working on those conversations. To be very honest with everybody, COVID-19 has pushed those conversations back because everybody was kind of underwater, including us and our centers, in trying to deal with the pandemic. But we think it's pretty important to get that formalized work group going forward with DOH to really dig into the details as soon as we hear what the budget cuts are. So those conversations are twofold. It's one, what are we doing to respond to the budget cuts that are coming out right now? And number two, what are we doing long-term in terms of this system? As Mr. Demple described, and something I think you guys have heard, at least the Labor Health Committee has heard from me before, is that all of these little bits and pieces, whether it's Medicaid payment reductions or insurance parity issues or reductions in state funding or grants disappearing, we're getting kind of a death by 1,000 cuts to the way the community mental health system operates right now. And so that's kind of where we are in those conversations. And with that, I'd be happy to stand for any questions.
Okay, questions for Andy? Committee, anything for Andy? All right, none. Thank you. Thank you very much. Appreciate it.
Chairman.
Cheryl Folland, Wyoming Association of Addiction. We have 2 speakers from the Wyoming Association of Addiction Professionals. Is that correct?
Sir, yes, that is correct. That is how they provided us their information on their forms.
Okay. Welcome back, Cheryl. Please.
There I am. Thank you, Mr. Chair, co-chair, and committee members. I just wanted to provide a little bit of information that both Andy and Paul were very direct on their centers reimbursements. I will tell you that private insurance, I have been getting some updates on telemedicine reimbursements. Blue Cross Blue Shield of Wyoming has extended their telemedicine benefit until 8/31 of 20. We're constantly seeing what's coming out from the private insurance carriers and also from CMS, who is the Center of Medicare Services, which kind of dictates policy for reimbursements. No, at this point, nobody really knows what telemedicine is going to continue to be like after the initial COVID responses. But at least as of right now, those reimbursements do occur, and that does include telephone. So they qualify it as any electronic means. Those reimbursements are fairly low and dependent upon the plans. The other challenge that at least the independent practitioners have in receiving Medicaid reimbursement and private insurance reimbursement is that you have to be credentialed and qualified as a substance abuse provider. So even though I'm a mental health provider and by law I'm able to provide certain substance abuse services, I may or may not be reimbursed for those services. So an ASI, I may or may not be reimbursed for. So I do a lot of pro bono in that aspect. So the reimbursements, I think, are cost savings for all of the providers, and other sources of funding, I believe, are available that the committee may ask to the Department of Corrections and Department of Health to investigate through some federal grants right now through SAMHSA and the National Institutes of Correction. and the other Bureau of Justice providers. So with that information, I stand for any questions.
Thank you. Any questions? Representative Larson.
Thank you, Mr. Chairman. Ms. Folland, you mentioned in your previous comments a little bit about certification, and then in this time you talk about credentialed, needing to be credentialed in order to be reimbursed, and I'm taking that as reimbursed by private insurance, but maybe you were referring to Medicaid. But help me to understand what the credential requirements are for you to be reimbursed. Is that back through the Department of Health, or is this a different accreditation process? And is it the same one as you referred to in your previous comments?
Mr. Chairman. Representative
Please,
Larson.
and to that I would add, I'm having trouble connecting up the idea of what it takes for you to get reimbursed with justice reinvestment and balancing the state budget. So if you tie that all out for me, I'd sure appreciate it, because I'm having trouble. I understand reimbursement difficulties and credentialing difficulties. I'm just trying to tie it out to what we're working on today. So help me understand.
Thank you, Mr. Chairman. Representative Larson. So as an independent provider, the insurance companies and Wyoming Medicaid as well require us to be credentialed with them as a provider. In most instances, you must be a master's level or higher for those reimbursements. So when I provide those services. A bachelor's level individual, for example, in this situation where a CSW or an addictions professional can bill, but they have to bill under a higher level provider. So someone higher up has to certify that the service was provided and that they agree with the diagnosis and the medical necessity.
I understand that. Yeah.
So, and each provider.
Are you advocating getting rid of that requirement as a solution? Do you want to get rid of that requirement, allow everybody at bachelor's level to bill direct without working under a master's? Is that where you're headed with that?
No, sir,
Okay.
Mr. Chair, no. What I'm saying is that is one of the obstacles for reimbursement, is that you have a bachelor's level individual has to have someone higher up certifying those services. As to your question about budget reductions, most of us are very aware, because our reimbursements come from Medicaid, from Medicare. We want to help the state be as efficient as possible and providing services to the criminal justice population, which is a very specialized population. And we are constantly looking to help the state and our agencies, our brother and sister agencies, be successful and looking for alternative funding sources. Sometimes as a private practitioner, I can obtain funding from other sources, nonprofit organizations that may or may not be part of WAMSAC also have opportunities for grants and other funding sources as well. So we're always looking to assist the state in finding options.
Thank you. Representative Larson.
Thank you, Mr. Chairman, and Eric will probably have to help me soon jump ship on us, but Cheryl, help me remember, but if you refer back to Medicaid a lot, but for mental illness and things of that nature, they don't reimburse for what is it, 19 to 65 anyway, which is the largest population that you have there. And so that I would it would seem to me that Medicaid reimbursement back to you would probably be not the primary source of reimbursement to you.
Please, Cheryl.
Thank you, Mr. Chairman, Representative Larson. You're absolutely right in the number of sessions that I can provide, as was raised earlier, has been expanded from 20 sessions for an adult to 30 sessions. Juveniles under the age of 18 and certain adults in various parts of the criminal justice system are in reimbursement is fairly low, but it is the primary source of revenue to us. It is very difficult.
Okay, anything else, Representative Larson? Senator Schuler.
Thank you, Mr. Chairman. Yeah, this question is for Cheryl. I don't know if it's possible. I've just been thinking about the fact that we know personnel costs are really the thing that drives, the cost so far up. And I wondered about, as an independent provider, because I know Mr. Demple mentioned about he might go to contracting services a bit. Is there a possibility that some of those of you, particularly you or others that do independent, could you contract more with our mental health centers? Or is that the issue that Andy Somerville mentioned about the fact that, the staffing, they're not competitive because they can't provide the same amount of money. So is there any possibility of maybe sharing services with psychologists or addiction personnel or whatever? Thank you.
Please, Ms. Folland.
Thank you, Mr. Chairman. Senator Schuler, yes, there are many independent practitioners who would absolutely consider contracting and assisting. And you're absolutely right. As Andy did bring up, they can't compete salary-wise. But most of, at least my membership and the peers that I work with would be happy to help and take some of the clients that are out there that need services.
Okay, thank you. Anything else for Cheryl? All right, Cheryl, thank you very much. Appreciate it. It's good to see you. Folks, it's just a few minutes before the noon hour. We've got two more folks, one more from Wyoming Association of Addiction Professionals and Representative Sweeney. As a colleague, I think I'm going to go ahead and take Representative Sweeney, and depending on how long that takes, we may just break for lunch at that point. So Representative Sweeney has asked for an opportunity to present on this topic overview of MHSA services through the criminal justice system.
Mr. Chairman, we believe Representative Sweeney had another obligation and was unsure he would be available in time to testify. So he is not in the waiting room at the moment, but we will keep our eye out for him.
All right, well then, Frank Craig, well, how long does Mr. Craig anticipate taking?
I am unsure, Mr. Chairman, as to how long his testimony was going to take.
Okay, he's probably not going to get it done in 5 minutes.
Mr. Chairman.
Yes, Mr. Representative Larson.
Representative Sweeney also serves on the State Building Commission for the House, and they're meeting this morning. So I would suspect that's probably where he's at.
All right. Let Mr. Craig know that we're going to pick him up after lunch, and let's just go ahead. I've got 11:56. I'm going to set an alarm for 30 minutes. We're scheduled for a 30-minute lunch. Let's do that, and then hopefully we can. Mr. Sweeney, Representative Sweeney probably won't be available, but we can fit Mr. Craig in 5 or 10 minutes and maybe get right back on schedule.
Mr. Chairman.
Yes, Elizabeth.
Mr. Chairman, for the members of the public who are watching the YouTube live stream, this live stream will not be active for the afternoon. We'll have a new link available, and that will go up about 10 minutes before we come back.
All right, well, that was important information to have. Thank you. And how do they find the link?
It is still on the legislative YouTube channel. The same link they use to find the AM version, they'll be able to use that to find the PM version.
All right, thank you so much. Representative Larson.
If I could just stumble on a little bit over several comments about the caps on Medicaid services. It was at 20, then it was raised to 30. But I believe the way that is, in Chairman Wilson or Representative Barlow can maybe help me out, but it seems to me like that after that cap, that does not eliminate services. That the provider just has to demonstrate that the patient or the client needs continued services, and an exception to that can be done. So I don't think that that's a hard and fast rule that once you hit 30 that you have to go home and never receive those services again.
I didn't take it that way.
Okay.
This is the whole Qualis system. It's just, in Qualis, I've got my own reservations. I think it ends up being a paper chase on some of these folks that are long-term mentally ill. To keep reviewing them every 20 visits or 30 visits is just a waste of everybody's time.
It's a Medicaid rule, but you can the exception requests go through Qualis.
Yeah, all right. So I'm going to set a timer for 30 minutes, and we'll see you all back here after a quick lunch. Thank you.
Thank you.